Hi, welcome everybody. We are ready to start the third session of this first day of the symposium. So I'm going to introduce our moderators, Giuseppe Cardillo and Gaetano Rocco from Italy and from US respectively. And they will moderate this session about thymoma and thymic carcinoma. So please go on.
Thank you. Thank you very much, Federico. It's a great pleasure for me and for my co-chair, Gaetano Rocco, to start the session on thymoma and thymic carcinoma. The first speaker will be Maninder Kalkat, and he will be update on stage and classification. Please, Maninder.
Greetings from United Kingdom. I'm grateful to ESTS for having given me the opportunity to discuss stage and classification for thymomas. I have no conflict of interest to declare. We stage the tumors so that we can group them together, look at their outcomes, discuss with our peers what best treatment regimen could be given, and majority of the solid tumors follow TNM classification paradigm. In TNM classification, we look at tumor, node, and metastasis descriptors, and then they are grouped together in a near homogeneous groups with respect to the survival of the patient. The thymic tumors are rare, the incidence being about 1.5 per million population. This is the commonest tumor in the anterior mediastinum. The thymic tumors are unusual. They spread locally. The prognosis is outcome, so you need a long-term follow-up. And majority of these series are by surgeons. They are small, and no wonder there are about 50 unique staging systems in circulation. The Masuoka-Kruger staging being the most commonly followed. Hence, there was indeed a need for a uniform TNM-based classification system, and for that matter, an international collaboration looked at about 10,000 cases across 105 hospitals. An 8th edition of TNM classification for thymic tumors was published in 2014, which has been endorsed by AGCC and UICC. But its adoption by the practice across the world still is dismal. We also need to know the WHO classification, which is based on the histology of the thymic tumors. Basically, 3 subtypes have been looked at and classified, and these are thymomas, thymic carcinomas, and thymic neuroendocrine tumors. There are further variety of histological subtypes. For example, in thymomas, it could be type A thymoma, AB, B1, B2, B3. And similarly, there are squamous cell carcinoma and thymic carcinoma, and further tumors are seen, but these are the commonest ones. And when we look at the WHO staging and histology and staging, there's a higher risk of recurrence and mortality in those patients with thymomas, which are B2 and onwards. The Masuoka-Kruger staging, as looked at here, was based on about 80 patients who were analyzed. It looks at basically a transcapsular invasion and then subclassifies into either sitting in stage 1 or stage 2. And once it goes beyond that, for example, into the pericardium, it becomes stage 3. The involvement of the lymph nodes sits in stage 4B, and similarly, the hematogenous metastasis as well. Although Massaoka-Koga staging is quite effective pathological staging system and has been in circulation for a long time, there are certain issues. One, that it comes basically from the surgical patients, and number two, little pre-treatment clinical information is added into the staging system. Looking at the TNM classifications, I'll go one by one through the various descriptors. In T stage, the involvement of the pericardium is T2, just remember that. And anything before that sits in T1. They have subclassified into T1A and T1B, depending on if there is invasion of the mediastinal pleura. Once it comes outside the pericardium, depending on the structures which are invaded, whether they are resectable, i.e. lung, brachiocephalic vein, SVC, phrenic nerve, chest wall, hilar pulmonary vessels, then it is T3. Anything which is unresectable, like aorta, intrapulmonary pulmonary artery, myocardium, esophagus or trachea, makes it T4. The N1 are the nodes lying in the anterior mediastinum, and N2 are the nodes which sit deep within the middle mediastinum, and similarly in the cervical region, deep or superficial. When we are looking at the M descriptor, any pleural or pericardial nodule separate from the tumor is M1A, and any nodule in the lung parenchyma or distant organ metastasis becomes M1B. Now, when we look at the stage migration and compare it with Massaoka-Koga staging, you can see there are more patients coming in TNM1 stage. Patients in MK-Koga staging 1, 2A, 2B, and even the mediastinal pleura involvement now sits in TNM stage 1. The pericardium remains in stage 2, whereas the resectable or not resectable structures have been separated into 3A and 3B. And this is important with regards to the surgery being planned. Similarly, pericardial pleural nodules are 4A, and N1 nodes still remains 4A. They are not 4B as in the previous Koga staging. Will this have an impact on treatment and survival? Time will tell. And this is again looking at the two staging systems in terms of the advanced stages. So ITMIC has certain stage-specific recommendation based on TNM classification. However, the basic essence of this is that complete surgical excision should be the goal. If there is any doubt about the completeness of the resection, then postoperative radiotherapy could be applied. Stage 3 tumors, which are borderline resectable, if there is again any doubt that it may not be resectable, consider induction therapy for some patients. But if there is a patient who have been operated upon with positive margins or doubtful margins, then again, both could be contemplated. The stage 4 tumors, a combined approach, majority of time it is systemic treatment which is required. So this is something which you just need to keep it in mind, that early stages, stage 1, stage 2, locally advanced stages 3A, 3B, and 4A, and up to 3A, majority of time, you will be able to undertake surgical resection. So I'll spend a little bit of time on this slide. And if you see, the stage 1 and stage 2 patients can be managed with minimally invasive treatment like VATS or radio or robotic surgery. And if the tumor has got possibility of positive margins, add radiotherapy, and also for those WHO histological classification of B2, B3, or thymic carcinoma or neuroendocrine tumors may require addition of adjuvant radiotherapy. Stage 3, again, if you are confident you can resect, go upfront surgery. But again, if there's any doubt, consider in the MDT whether neoadjuvant treatment could be an option. The stage 3B is unresectable, but again, whether surgery could be added at some stage needs open to discussion in the MDT with the oncological and surgical teams. This is very important. The new recommendation is that all anterior and lower anterior cervical lymph nodes have to be removed in every stage. Okay, so this is important. This is a take-home message. But in case of the patients who are, say, stage 3 onwards, even the deep lymph nodes need to be taken. So if you are resecting any stage 3A, which is invasion into the resectable structures, then you must take the deeper lymph nodes out and onwards. Every patient or thymic carcinoma, all lymph nodes need to be removed. The future is, of course, further iteration of this TNM classification. The 9th revision will be published in 2024. We will have some preliminary results next year. So the implication and conclusions are that we should aim for complete R0 resections for the patient with these thymic tumors. The lymph node dissection is important and is a key ITMIC recommendation. This is a standardized criteria for invasion as opposed to broad classification for Masuoka-Koga staging. Now, these stage migrations open up more patients to neoadjuvant and adjuvant treatment and possibly post-operative radiotherapy. Thank you very much.
Thank you very much, Maninder. Before moving on to the next presentation, just want to remind that this is meant to be an interactive session. We are looking forward to your comments and questions in the Q&A chat. It's now the time for Professor Nuria Novoa to talk to us about the role of imaging in histology, stage, and prognosis determination in patients referred to surgery for thymoma. Nuria, please.
Chairman, colleagues, first of all, I want to thank the organizers for their kind invitation to participate in this course. I have no relevant disclosures to report about this presentation. These are the main messages I wanted to keep in mind after this talk. We will go through all these different areas during this presentation, and we are going to start reviewing some background concepts that will help us to understand the revolution involved in what I'm going to cover. I'm sure that everybody agrees that thymomas are malignant or rare malignant tumors, and it's only a matter of time for them to behave like it, independently of their histological type. But it is very important to note that we are more frequently than before, we are diagnosing thymomas in asymptomatic patients. Remember that myasthenia gravis occurs in 30 to 50% of patients with thymoma, and only in 10 to 15 patients with myasthenia will have thymomas. This means that we need to obtain the maximum possible information from those non-invasive radiological and metabolical techniques to help our patients. In summary, image findings do impact on treatment. We are going to see this impact especially with innovative concepts of radiomics. The progress in data mining allow the transfer of medical images into quantitative data that can be mathematically analyzed. Let's start reviewing the value of the World Health Organization pathological classification. Back in 2008, after this meta-analysis, we all accepted the different average overall survival of the different World Health histological subtypes of thymoma. However, applying statistical mathematical analysis, we found that differences were not between all types, but between the aggregate subtypes that were clearly different. However, although we cannot deny that pathological classification has some clinical impact, the real key points of thymic tumors management are the stage of the disease at the moment of diagnosis and the completeness of resection. This statement reduces the stress toward the need of harvesting a sample of pathological diagnosis and rests a great responsibility on the radiologist's shoulders. Because radiological image can tell us a lot about the problem we are facing, we are going to review some useful findings that we can see in both in CT and in magnetic resonance. In 2002, Tomiyama and co-workers made a complete analysis of qualitative features of the thymomas. They identify at least 8 important features to review, as you can see highlighted here in this table. For instance, they analyzed the contour of the tumor and found that it tends to be smooth in type A type of tumors, of this one, also in type AB or in type B1, and found that images follow the same pattern when looking at the magnetic resonance images. But when we look at type B3, for instance, the contour was not as smooth as it was before. Authors summarize in their paper in this table that type A to type B2 have very smooth contour, while it can be lobulated in types AB to B3, and when it was clearly irregular, it means that we have capsular invasion and probably we are facing a thymic carcinoma. They also look at another feature, calcifications. Here we can see an infrequent situation in which we have a complete peripheral calcification of the tumor. And here there's another more frequent single isolated calcification inside the tumor. But sometimes what we see most often is multiple calcifications inside or around or in different parts of the peripheral area of the tumor. What was most interesting is that calcifications, when appear, only in groups B1 to B3 types of thymoma. There are also other features to look at. For instance, the enhancement pattern after IV infusion of contrast. As you can see here, this AB tumor shows an homogeneous enhancement pattern. That image clearly contrasts and is different to this B3 tumor that shows a great heterogeneity. Again, the pattern is reproduced in the magnetic resonance images, and it seems to be due to necrosis, cystic changes, or hemorrhage within the same tumor. According to some series, homogeneous enhancement occurs in types A to B2, but not in type B3 or in thymic cancer. Another interesting feature of the enhancement is the amount of acquired contrast in the tumor. It is low, as in these images, in types B1 and B2, and this feature has been related to the high proportion of lymphocytes present in those tumors. But moving from diagnosis to treatment, imaging does help us because of the findings we have already reviewed, and especially because it provides us information about the staging of the tumor. And when we think about the staging, some of us will think about the Masaoka staging system because we are using it in a daily basis. But this classification is not helpful at the moment of diagnosis because it needs some pathological data not available at the initial moment. This is another reason to use the TNM system. The collected radiological information will classify patients as those who will benefit from neoadjuvant treatment and those who will not. For instance, stage 3 due to vascular invasion, as we can see here, can be seen as an irregular basal lumen contour. It can be implied because of the vascular obliteration or because of the presence of endoluminal soft tissue, as in this case. Pleural involvement will appear like a drop metastasis, masses of diffuse or diffuse infiltrate of the tumor, and always remember, although it could be some pleural metastasis, but it's very infrequent to have a pleural effusion. So when we have this pleural effusion, we can think about something, a different pathological entity. Also, the surrounding fatty tissue invasion. This can be clearly seen not only in CT but also in magnetic resonance imaging. According to Maron and co-workers, a tumor bigger than 7 centimeters that shows fatty tissue infiltration and lobulated contours are in stage 3 or 4 and probably have a very high degree of aggressiveness. Let us move into the quantitative world of radiomics. As I said, this is an emerging field that translates medical images into quantitative data. As you can see in the timeline, it was in 2012, when the term was coined. Thanks to great developments in technology, this is a reliable tool. It allows the extraction of quantifiable features to find correlations with clinical outcomes or with the underlying biology using learning analysis techniques. Image information is transferred into numeric data that we can work with. How does it work? First, we acquire the medical image. Second, we define a region of interest to work with. Then we will extract the data of the specific feature we want to study, and finally, mathematically, we correlate our data with the diagnostic and prognostic outcomes. Does the radiomics data help us with tumors? In this study, authors analyzed image predictors of high-risk thymomas. They developed 3 models. One, the clinical model, very simple. Second, the conventional model in which multiple qualitative variables are included. And finally, the complete model that includes a radiomics signature, or which means a summary of quantitative data on multiple image features. After a multivariate analysis, they found that tumor shape, apparent diffusion coefficient, which is a radiological variable. And the radionic signature were significant to diagnose a high-risk thymoma. With these variables, they created a nomogram, and using artificial intelligence techniques, teach the machine using a training subgroup of patients and apply the knowledge to a new population of patients to obtain outstanding results. As we can see in the curves, in the broad curves, they obtain an area under the curve of 0.94 in the training subgroup, which is outstanding, and an area under the curve of 0.878 in the test subgroup, meaning that this nomogram is very accurate. Radiomics can be applied to the results of different machines, but PET-CT has a pretty well-defined protocols making data analysis efficient and accurate. This is why radiomics grew in close relation to the PET development. You can see in this image a timeline indicating crucial phases of the evolution of PET and radiomics. All milestones have been reached using the standardized update value, the maximum standardized update value. This is a semi-quantitative parameter. It is obtained from one pixel region of interest, and it depends strongly on noise. When there is a lot of noise, it can behave in an unpredictable manner, like when we have a tumor that is on top of the myocardium. It does not represent, and at the same time it has another disadvantage, that is that it does not represent the total tumor mass. However, there are some volumetric parameters that really represent the metabolically active tumor cells. Those variables provide information about the tumor burden and its aggressiveness. I am referring to the metabolic tumor volume, the total lesion glycolysis, and the minimum, maximum, and average standardized uptake value. And how do we calculate this? We have the PET image, as you can see here in the figure A, and we will define the volume of interest that we want to work with. Over the basic PET image of the tumor, we ask the machine to draw an area in which all pixels have a certain standardized uptake value, for instance 2.5. Then the machine provides the three images of the region of interest of the tumor. Adding these three images, we have a volume of interest for analysis. And what has been found with this technology? There are some conflicting results. For instance, in this paper, authors showed the image of a TEP AV tumor versus a thymic carcinoma. Apparent SUV are exactly the same. However, in the review of the literature, they perform at the same as they perform their own data analysis. Some papers found an overlap of standardized values between the aggregate pathological types and other found, and meanwhile other authors found great differences. But it seems that the more aggressive the tumor is, the higher the standardized uptake value will be as an average. In the same paper, coming back not to the review of the literature, but to their own values, authors found that metabolic tumor volume and the total lesion glycolysis were significantly different depending on the pathological group. However, no one of those parameters did clearly influence the progression-free survival of the series. So again, we have some conflicting results. However, although differences were not significant from a statistical point of view, they found that they have higher values in patients having a recurrent disease. In another different recent study by Lee and co-workers, authors found that at the univariate analysis, all the volumetric parameters were significantly related to the disease-free survival of the patients. But after the multivariate analysis, only the average standardized uptake value was able to predict disease-free survival of the series, meaning that future large multi-center studies are really needed. So in conclusion, I would say that image findings have a great impact on diagnosis and treatment. CT and magnetic resonance are useful defining the stage of the thymic tumor and its aggressivity. PET avidity tend to be higher in thymic carcinoma than in thymomas, and quantitative image analysis of PET parameters provide information about the biological behavior of the tumor, especially metabolic tumor volume and total lesion glycolysis. And also would say that radiographic criteria can predict prognostic group, helping to guide decisions about neoadjuvant treatment. Well, thank you very much for your attention.
Thank you very much, Maria, for your presentation. The next speaker will be Kostas Papagiannopoulos, consultant from Leeds. He will talk with the prognostic factors for surgically treated thymoma and thymic carcinoma. Please, Kostas.
I would like to thank the organizing committee for providing another superb conference with key opinion leaders in the field of thoracic surgery, and ESTS for embracing such an important event. I'm Kostas Papagiannopoulos, and I'm a senior consultant thoracic surgeon in Leeds, UK, and I have served as a past president and the treasurer of the European Society of Thoracic Surgery. Following the insights of the previous speakers, I was offered the opportunity to discuss prognostic factors for surgically treated thymic pathology. I have nothing to disclose. Just for your reference and refreshing your memory, I have inserted the Massaoka-Koga classification. It remains a valid system in the majority of institutions dealing with thymic disease. Early stage disease, as you can see from the staging system, should be relatively easy to remove with a complete resection, with more challenges arising with the later stage of the disease when tumors are infiltrating mediastinal neighbors, rendering the surgical resection and prognosis questionable. Although the thymic tumors present in variable stages and histological atypia, from the very simple and completely encapsulated to the more advanced and infiltrating, as you can see in these pictures, it seems that surgery remains the mainstay of treatment, even in the advanced stages of the disease. A treatment which would have never been anticipated in other thoracic malignancies, but at times receiving criticism from non-surgical specialties. So, are there any prognostic factors for surgically treated thymic malignancies or thymic tumors, and do we know of any of those ones that they're really important? There are several prognostic factors which have been evaluated and tested when overall survival and freedom from resection, freedom from recurrence are discussed in thymic tumors. I have picked up in this slide some of the most discussed ones, either as independent or covariates in multivariate analysis. We can see that completeness of resection is discussed in papers, WHO classification and stage, unless the tumor size, the invasion of surrounding neighbors like great vessels, and the age of the patient. To my opinion, the conclusions are flawed sometimes by the lack of large prospective studies, the study samples and the presence of variability. Sometimes we have minor or major deviations from the standard pathways. We have sometimes absence of standardized pathways or treatment pathways, and obviously the consensus on staging and the extent of the resection. Let's have a look at some of the early papers. This is a paper from the group of Levasseur, where they looked at 307 patients in 1996. This was a retrospective analysis, 260 complete resections performed, and they used a Verley-Holman classification with a mean follow-up of 8 years. As you can see from the graph, there was no significant difference between stage 1 and stage 2 disease when it comes to overall survival on surgically resected thymiomas. There was a significant difference, excuse me, between stages 2 and 3 in the overall survival. And again, no significant difference between stages 3 and 4. The survival was better for stage 3 completely resected thymiomas compared to complete resection, with 70% versus 31% overall survival. Also, when dissecting the group of patients, the survival was better for completely resected stage 3 disease compared to stage 4, measured at 75 and 42%. And also there was no difference in the survival measured on stage 4 in those with complete or incomplete resections. If we look at the survival by the completeness of the resection, as I said, 260 patients had a complete resection, 47 had incomplete resection. It is obvious that the 10-year survival is very much different between the R0 and R1, which was 76 and 28% respectively. In this specific paper, R1 was the mixed group of patients for those that they had an attempted and incomplete resection, as well as those that they had no resection up front and only a biopsy. So the group also looked at the need or possible benefits from adjuvant radiotherapy. 114 patients with completely resected thymiomas at stage 2 and 3, they had adjuvant treatment. 80% of them managed to complete the postoperative radiotherapy. There was no survival difference between the stages 2 and 3, and in all completely resected disease. Excuse me. So adjuvant radiotherapy might prove more beneficial, in all honesty, in patients that they have an incomplete resection, but also the adjuvant treatment, as we know very well, might depend very much on the preference of an institution, how risk averse the oncology group is, and obviously the extent of the surgical bed that has been required to be irradiated. Now, if we look at the survival according to the histological classification, there was no significance between stages 1 and 2. There was a borderline significance between stage 2 and 3, and there was a significant survival difference between stages 3 and 4. So the group went on to look at prognostic factors on surgically treated thymiomas, and they did a univariate analysis. By far, the completeness of the resection was a very significant prognostic factor, followed by the Massaoka clinical stage, as well as the histological classification. But when one thinks, utilizes common sense, obviously, the more advanced the disease is and the more aggressive the tumor is, the less are the chances that you do have to complete a resection. So those three prognostic factors, they essentially link to each other. So the group went on to look at multivariate analysis. They used 5 covariates, which was the completeness of the resection, the Massaoka stage, the histological stage, the presence of myasthenia, and the postoperative radiotherapy. And in multivariate analysis, the completeness of resection came up as a very strong prognostic factor for surgically treated thymiomas, with Massaoka stage being less important. When one of the covariates was knocked off, and essentially the completeness of resection, then obviously Massaoka stage was upstaged as a very important prognostic factor. But in the multivariate analysis overall, the histological classification did not come up as a strong prognostic factor. Let's have a look at another paper. The main reason that I have decided to add this in my presentation was because the group with our past president Enrico Ruffini has looked specifically at the thymic carcinomas, and I thought, well, let's have a look at the more aggressive tumors and see whether prognostic factors are very similar to the less aggressive ones in the management overall of thymic pathology. This paper was published in 2014. The database is the ESTS database that contained 2,265 patients, from which 10% approximately were thymic carcinomas. This is though a 20-year period of collection of data from 36 different institutions with the variability most probably of treatment, R0 resection at 69%, and stage 3 and 4 disease at 71%. It is very obvious from this slide that the essentially survival curves show that the overall survival is very different between early stages 1 and 2 and stages essentially 3 and 4. What is interesting on this paper is that the complete resection obviously proves to be a strong prognostic factor compared to the patients that they have received an incomplete resection. But this group also showed that even the attempted resection, even if it is incomplete, fares a better survival, overall survival, than those patients that they were not accepted for surgery at all and had a simple biopsy. What I would say here is that the completeness of the resection is not just an important prognostic factor, but it is also a prognostic factor that can be influenced by the skills and the experience of the surgical team. And I think that is something that we need to keep in mind. The group looked also on the overall survival on patients that they did have a multidisciplinary type of a treatment, and it was favorable in all types of multidisciplinary treatments. But the one that had essentially the best overall survival was the patients that they had surgery followed by adjuvant radiotherapy. This is the gist of the paper on the covariates utilized in multivariate analysis and also the univariate model. We can see actually that age, the resection status, complete versus incomplete, the Massaoka Koga stage are strong prognostic factors on multivariate analysis. And then overall, the use of adjuvant therapy has been a prognostic factor as well. When we're looking at the freedom from recurrence in the univariate model, the tumor size seemed to be a prognostic factor. So when one dissects several papers, including the ones that I've showed you in this presentation, it seems that the patients with a complete surgical excision on clearly resectable tumors, with or without adjuvant radiotherapy, seem to be having an overall good prognosis. But for those that they have locally advanced tumors, the neoadjuvant treatment might be an accepted protocol, but the complete resection remains again the main prognostic factor. And a word of caution, advanced disease stage 3 and 4 is not an homogeneous group of patients, as the anatomical presentation might be different. And if you look at those two little pictures, those two patients might be classed as stage 3 disease, but obviously the completeness of resection would have been questionable if you compare those two patients, and therefore, although they have the same stage, they might not have the same overall prognosis. So if I'm allowed to say, it translates that the most significant prognostic factor for surgically treated thymic tumors is a multidisciplinary approach, or best described, a multidisciplinary attitude. Let's have a look at this first case. It's a 60-year-old male with a thymic carcinoma, which has mainly a squamous differentiation, no comorbidities, and expected stage 3 when we're looking at the CT scan. He presented mainly with constitutional symptoms and some shortness of breath. I think in this patient, clearly, although it looks like a stage 3, you would be very much worried about the infiltrative aspect of the tumor down into the pericardium, and also tumor coming down into the paratracheal area in between the SVC and the ascending aorta. But we know that surgery is flagged up as the most important prognostic factor. So the question that arises for a surgeon is, can I do it? Can I offer a complete resection? Do I need a neoadjuvant treatment in this case? How am I going to attack this? And is the patient going to need an adjuvant treatment? And is there going to be an agreed treatment pathway in the institution that I am? In this patient, we performed a sternotomy with a complete resection, an SVC resection and reconstruction, pericardial resection. The right phrenic nerve was sacrificed with a pericardium. There was a innominate vein resection, a wedge resection of the right upper lobe, and a prophylactic diaphragmatic plication. He had been accepted for adjuvant radiotherapy, so he completed the treatment pathway as per UNIT's protocol. This is another case, an 80-year-old lady that had no significant comorbidities with a thymic mass and presents mainly with a shortness of breath. Again, we are expecting that this lady is having essentially a, that she's having a stage 3 thymic mass. You can see that this this looks a little bit different. Let me just get the video again. It looks a little bit different. Is a very large mass which is occupying a very large part of the left upper part of the hemithorax, creeps up on the aortic arch. It might be infiltrating the innominate vein. And again, the question that arises here is whether you are able to offer a complete resection in this patient, which will be an important prognostic factor. How are you going to approach this? Whether she will need to have neoadjuvant treatment or whether she just needs to have a upfront resection with or without an adjuvant treatment after that. We were able to provide a complete resection with a partial sternotomy and an anterior approach, which was a hemiclamshal incision, resect the innominate vein, and offer a wedge of the left upper lobe, which was performed. And then the question that arises is, does she really need adjuvant radiotherapy because her natural survival curve might essentially overlap her expected survival curve if she was to be given a complete resection with adjuvant treatment? This is another case. This is a 65-year-old patient who has been troubled with asthma for 2 years, but eventually had a CT scan which revealed that she did have essentially a thymic mass and a agreed specialist center regional unit treatment pathway. When she came to our specialist unit, we identified her as having a good syndrome, and this was classed initially as asthma. Do we class this patient as a stage 4? Perhaps we can, but then we need to know what is the next treatment that she needs to have. And again, surgery is the most important prognostic factor. So again, what is the approach on this patient? Is it the same as it was in patient 1 and 2? Are you comfortable that you can offer her an R0 resection, and what are your expectations? So in this situation, we decided to go ahead with surgery, but in a staged approach. We offer her a right VATS, and we managed to resect completely the single pleural met. Had she had multiple metastases, we might have decided not to go ahead with the surgery. She did have, therefore, a sternotomy and a complete resection of the mass with the pericardium, the innominate vein. We did a patch repair of the SVC. We resected the right phrenic nerve, but she had also an intrapericardial anterior anatomical segmentectomy of the lung. You can see the right main PA down here with the truncus branch, with the anterior branch, which has been knocked off, and also the tributary of the superior pulmonary vein, because we wanted to come underneath and ascend past the tumor. She did have a prophylactic diaphragmatic plication as well, but then when we discussed it, oncology did not accept her for radiotherapy because they considered that the side effects and the toxicity might have been very high. So the question on this one is, has she been offered an agreed pathway which includes all prognostic factors for a good overall survival? Dear colleagues, The survival of patients treated for thymic tumors is directly related to the skills of the operating surgeon. His or her ability to influence the best pathway for each individual patient, as he or she are the most relevant persons to judge the resectability and successfully undertake a complete resection. So the MDT, the tumor board, should be the appropriate vehicle that you can offer an agreed team approach and consensus, setting the expectations of the patient, treatment, and the team correctly, and you should be able then to guarantee a successful and tailored best treatment pathway for the individual patient with all prognostic factors, including for a good overall survival. And with this, I would like to thank you all for your attention. And again, the organizing committee for such a lovely meeting, and ESTS for embracing that event. Thank you.
Thank you, Kostas. We now move on to surgery for recurrent thymoma or thymic carcinoma. Our speaker will be Dr. Soley from Bologna. Get Giorgio, please.
Good afternoon, everyone. First of all, I would like to say thank you to Federico Raveglia for this very kind invitation. It is a pleasure to be here with this ESTS Thoracic Oncology Symposium 2021. The topic I was given is the role of surgery for recurrent thymoma. These are my disclosures. And I set an agenda where I will get through some general data and some epidemiology of these tumors. We'll try to offer you an overview of the patterns of relapse and of predictors of recurrence, results of the role of surgery, a few words about the role of the bulking surgery, the role of the intrathoracic hyperthermic intrapleural chemotherapy, some guidelines on surveillance, new drugs trials, and the role of a thymectomy. We know from the literature that these are an heterogeneous group of rare thoracic cancer with an annual incidence ranging from 1.3 to 3.2 per millions. We know that the thymic carcinoma are less frequent, 6-7 times less than thymomas. In generally speaking, they are very rare cancer, but still they are the most commonly solitary lesion discovered incidentally in the anterior mediastinum. The peak of incidence is between 40 and 60 years of age, with no difference between males and females, and with a variable correlation with myasthenia gravis. We know that more advanced WHO histology type B1, 2, and 3 thymoma tends to be more frequently associated with myasthenia, where it is definitely rare and occasionally that thymic carcinoma is associated with myasthenia gravis. In terms of relapse, we know that these are tumors with a very indolent history and behavior, and the relapse is often unpredictable. The recurrence rate is something about between 10 and 30%, even after a radical resection, may occur after a very long period of time, even after 20 years. Most of these recurrences are locoregional, so it means pleural, mediastinum, and diaphragm, rather than distant hematogenous. And when we say, often when we say distant metastatic spreads, frequently we are referring to relapse limited to the lung. This is a paper coming from the group of Boston, published on JTCVS on 2005. And they try to analyze predictors of recurrence. And then they discovered that the most important factor is the completeness of resection. as well as the size of the tumors with a higher frequency of relapsing tumor more than 5 centimeters and more than 8 centimeters. There is a strict correlation with the WHO histology classification where B2 and B3 tumors tend to have a more higher chance of recurrence, and also with the Masa-Oka stage. The time of recurrence may vary according to the thymoma stage, and we know that the stage 1 thymoma may experience recurrence even after 10 or 20 years, while more advanced stage 2, 3, and 4 Masa-Oka stage can have a recurrence within the first years after surgical resection. The International Thymic Malignancy Interest Group, the ITMIC group, have tried to classify and define the patterns of relapse. You see on the left side this table reporting the classification in 3 subgroups, where patients with experience local recurrence in the anterior mediastinum. These are the recurrence located in the bed of the previous resected thymoma, or including the pericardium, the pleura, or the lung, where this was immediately adjacent or it was included in the first resection. Then we have the local regional recurrence. These are where this happened intrathoracically, but not in area that were contiguous with the previous thymoma. So it means the viscera or parietal pleural nodules or pericardial nodules or mediastinal nodes. And then the last group are the distance, the recurrence that occur distantly. So these are extrathoracic. Most of them, as said, are within the lung. The ITMIC group, with this paper published on JTO last year, tried to analyze if this classification fits well with the overall survival, and surprisingly, they discovered that actually doesn't fit very well, and other type of classification fits much better with the overall survival, especially when you have single or multiple recurrence. And again, the groups are very well stratified when you consider patients who have an intrathoracic single, or an intrathoracic multiple, or extrathoracic disease. And you see all of these elements are significantly, statistically significant at the univariate and multivariate analysis. When we are discussing studies addressing the role of surgery in recurrence of thymoma, we should keep in mind that most of the study, I would say all of the study, present some biases. First of all, none of them are randomized. Moreover, the vast majority of them use some selection criteria that then reflects in results. For instance, most of the study are focused on Masa-Oka stage 1, 2, and 3, and are not including Masa-Oka stage 4 disease. Most of the studies are focused on thymoma from 1 to B3 classification and exclude thymic carcinoma. Most of the study tends to exclude patients with relapse or patients who had at the beginning incomplete resection. And for this reason, the comparison between patients that are treated surgically and patients that are treated with other therapies are often artificial and inappropriate. Also because the different extension, single versus multiply, the different location of the disease, local versus distance, and also because surgery tends to be offered more frequently to patients with a better performance status. I'm going to present now a few papers addressing the role of surgery in this context. So this is the first one, is coming from Japan and US United colleagues, and it's been published on Annals of Thoracic Surgery in 2014, and is analyzed 11 studies reporting survival at 5 and 10 years according to different strategy of treatment. And you see that pulling together all the data, there is an evident advantage for patients who received a surgery instead of patients that were treated non-surgically. 81.9% 5-year survivors compared to 48 and 66 compared to 23. You see the forest plot analyzing the first one, letter A, 10-year survival after recurrence, letter B, 5-year survival after the treatment of the recurrence, and 5-year survival after the treatment of the recurrence in patients that were treated surgically and non-surgically. And you see that all of these Farrell-Plast tables are in favor of the surgical treatment. But the authors also stressed that this study are constrained by multiple limitations because of the studies from which they are composed. So essentially, data on fitness for surgery and on the extent of the disease as time of relapse was not clearly mentioned. So this is a factor that will select patients in favor or against resection. From this paper, we know that non-surgical candidates tended to have more distant disease. The majority of the studies did not provide the number of the recurrences. There were no data enough to supporting or to deny the fact that patients with a disseminated recurrence may benefit from surgery. And essentially, there was a lack of information of new adjuvant or adjuvant treatments that was in any way addressed to patients surgically managed. This is a second paper published on JTO in 2015. It's coming from a Japanese nationwide registry. It includes 32 Japanese institutions for a total of 2,035 patients with thymic epithelial tumors surgically treated. It is a retrospective collection along 30 years, and you see that almost 15% of the cases experienced a recurrence. This was divided in 162 patients that were surgically treated. This is a second paper coming from the Japanese nationwide registry that includes 32 institutes for a total of more than 2,000 cases collected along a 30 years period of time, and there were all patients surgically treated for a thymic epithelial tumors. You see that 15 of the cases experienced a recurrence, and 162 were treated surgically and 243 were treated non-surgically. The 5-year and 10-year post-recurrence overall survival is in any case in favor of the surgical group. You see is 82 compared to 43%, and at 10 years 68 compared to 25%. The authors analyzed the prognostic factors in the surgical group, and they discovered that the sex female, early stage 1 and 2 Masaoka, thymoma, non-thymic carcinoma, the use of preoperative treatment, and a longer free interval from the disease before relapse, more than 3 years, were all significant factors. Interestingly, the radical resection of the recurrence was not a significant factor. On the right side, you see the overall survival. You see in the curves on the top A, the overall survival after recurrence that is in favor of surgery. And then this is divided in case of complete resection, the figure B, and in case of incomplete resection. You see, in both of the cases, there was a survival advantage for the surgical group. Interestingly, the Mizuno analyzed also the role of non-radical surgery compared to radical surgery, and patient medically treated. And you see from the curves in the lower part of the diagram that there was noted a survival advantage for R0, R1 compared to non-surgical group for each histology. The advantage over patient treated with R2 was intermediate between R0 and R1 and the non-surgical group for thymomas, although this difference between patient treated with R2 and non-surgically was not significant for either histology. And you can see this is the letter A, the curve for all the histology. Letter B is for the thymoma histology, and letter C is for the thymic carcinoma. Another paper is coming from the Italian multi-institutional 4 units across Italy of thoracic surgery between 30 years time. It's been published in European Journal of Cardiothoracic Surgery 2016. It includes 880 patients with thymoma who underwent complete macroscopic resection. There were follow-up for their recurrence. Masaoka stage 4 and type C thymic carcinoma tumor were excluded from the study. You see that there was 82 cases with a recurrence, making a percentage of 9.3%. 52 of them were reoperated, and additionally 21 patients were treated surgically and were referred to this hospital but originally operated outside. So making the overall calculation, a study cohort of 103 cases, 73 reoperated and 30 receiving medical treatment. You see that Professor Marulli found that there was a survival advantage for patients receiving surgery, and on multivariate analysis, the completeness of the resection, the number of deposits, the Masaoka stage of the primary tumor, and the site of relapse were all independent prognostic factors. So in conclusion, reduced surgery for recurrent thymoma is achieving effective and prolonged survival. Complete macroscopic resection and single recurrence are associated with a better prognosis. This is the last paper I'm going to present you. Is a very comprehensive review and meta-analysis proposed by the Dr. Chiappetta, and has been published on Cancer in 2021, so this year. It is a very comprehensive literature research according to the PRISMA guidelines. It includes studies published in along a 40-year period of time. So the criteria for inclusion and exclusion were only cohorts with more than 30 patients, comparing surgical and non-surgical approaches, only studies reporting data from the first recurrence and with survival analysis. All studies, including thymic carcinoma, were excluded unless they were presenting survival analysis data for thymoma cases. So in the end, they selected nine studies for a total of 978 patients. There was non-randomized clinical trials, and all were retrospective case series coming from 5 from Europe and 6 from Europe and 3 from Asia. So the key message was that overall survival was better after surgical treatment when compared to other treatment. In 2 studies, the survival comparison were performed between patients receiving complete resection and those under incomplete resection or other treatment. Going into details and into the quantitative analysis done on 706 patients, you see that most of them received surgery, and The others were a combination of chemo or radiotherapy or both, and pooling all the results together, you see that there was a risk of 0.39 with a moderate heterogeneity amongst others, all in favor of the surgical group. They analyzed also other factors affecting survival. In two studies, myasthenia gravis was found as an independent, favorable prognostic factor for survival, while in the remaining 5, there was no difference. In terms of histology, all papers except one stratified the overall survival by the original WHO histology of the primary thymoma, and of course, A and B1 thymoma had a better survival, and all studies noted a change. Most of the study noted a change in histology comparing to the primary thymoma with the recurrence, with the transition to a higher grade. Pattern, in terms of pattern of recurrence, they observed that there was a better survival with local compared to distant recurrence, a better survival with single compared to multiple localization, and the vast majority of the distant recurrence were localized in the lung and was in 90% of the cases surgically resected. Just a few words in terms of the role of the debulking surgery. So again, we are jumping back to the paper of Mizuno published on JTO in 2015. And we have to say that in general, this is a topic that is not extensively addressed in the literature, and that's why it remains unclear. You see that there is overall a better survival rate in complete versus incomplete resect in the vast majority of the studies, but likely, according to the study, R1 cases could have potentially a similar survival than R0 cases, while R2 have an intermediate outcome between R1, R0, and the other treatment. But we have to notice again, and this is again a limitation, that around half of the patients received other treatment that were integrated with different protocol before or after recurrence surgery. We know from literature that patients with thymoma can experience a second tumor. These are two publications, one from JAMA 2000 and another one from the National Journal of Cancer 2003, stressing that as high as 28% of the patients after thymoma have an increased risk of developing a second cancer. You see, the standardized incidence ratio compared to number of cases normally expected in the general population is 4.7 higher for B-cell lymphoma, 1.8 for gastrointestinal cancer, and more than 10 times for soft tissue sarcoma. And this has been again stressed in the JAMA paper. And this paper coming from Cancer in 2001 was trying to analyze if the risk was associated with some factors, and the risk unfortunately appeared to be intrinsic and not related to any other factor, including age, length of the follow-up, myasthenia gravis, type of thymectomy, stage of the disease, and use or not of radiotherapy. Some authors advocate the use of hyperthermic intrathoracic chemotherapy for thymoma. You see, this is a very a nice and very extensive review on indication and results coming from the group of PISA led by Professor Marco Lucchi. Is applying this technique in stage 4 thymoma presentation, or in any case of recurrence occurring with pleural, pericardial, or diaphragmatic deposits. Outlook is imagined as something alternative to extrapleural pneumonectomy and is performed after a macroscopic radical resection with the intent to improve local control and reduce recurrence rate. There are different protocols according to these authors. The standard dosage of cisplatin plus epirubicin is a good option. They used to leave 2 drains at the end of the resection and irrigate extensively the pleural cavity for 60 consecutive minutes. They didn't observe any related significant side effects, and there was a good local and control with no mortality. Of course, all this evidence is confined to retrospective study with few patients and all applying different protocol. But in the end, this approach proved to be safe, feasible, with a low rate of complication, negligible systemic effects of chemotherapeutic agents, and was effective in controlling local and disease-free survival. And this is the same concept that comes from the paper that was published a few years before, again from Professor Luckett, with this technique, and showing that patients utilizing high TOC have a better survival compared to patients who are using surgery alone. And of course, patients who had a R0 surgery had a better outcome, but especially the disease-free interval was affected by the use of iTalk, both of the univariate analysis and multivariate analysis with a statistical significance. When we discuss about these tumors, we said they are tumors who had a long-term recurrence, so many societies are developing guidelines. This is the last one coming from the NCCN, and you see that they recommend a CT scan every 6 months for 2 years, then annually for 5 years for thymic carcinoma and for 10 years for thymoma. As mentioned before, we should not only consider surgery, there are other treatments. We know that at the moment, platinum-based chemotherapy is the standard, gold standard first-line treatment for patients with advanced recurrences. But at the moment, some trials are ongoing, and we know that there are new target therapies, including anti-angiogenetic drugs, some mTOR and PI3K inhibitors, as well as immune checkpoint inhibitors, and these drugs are tested in a different combination and different protocols. So I really invite you to read this very comprehensive recent review from Professor De Paz from European Institute of Oncology in Milan. Just one slide to discuss the topic of the robotic extended rate thymectomy. This is a very interesting paper on only 6 cases coming from Professor Rucker from Berlin. He's applying this technique in when you have 2 out of 3 of the following criteria. So a patient who has been operated, and after 2 years, after that myasthenic symptoms subsided, start re-deteriorating again. So, or patient where the first resection proved to be incomplete, and you got some video documentation or some radiology imaging showing the expected residual tumor tissue, or eventually when you got a complete resection, but then after 2 years on radiology, you discover some unexpected tissue residual. So if you got 2 out of these criteria, you should consider your patient for a rethymectomy, and you see that robotic was able to identify the residual tissue, and that this is associated with an improvement in symptoms or in a reduction of therapeutic dose of drugs in about half of the cases. And the author says that robotic extended rate thymectomy should be seen as an alternative to the conventional transdermal or thoracoscopic approach that are offering equivalent clinical outcomes. So I'm going to conclude my presentation with my take-home message, saying that surgery, when technically feasible, is associated with favorable long-term outcomes, should be considered as a fundamental part of integrated multimodality treatment. We should be aware that most of the studies are affected by some bias, and there should potentially be a role for R1 debulking surgery, but again, this has not been addressed properly in the study, so should be keep in mind. And that iTalk seems to be an interesting tool for the treatment of intrathoracic only relapse. And the last message I wanna give you is that we should never forget, and I invite you to read this recently published paper on by Professor Guerrera addressing the topic of the role of thymotomectomy versus thymomectomy, and we know from this paper that patients who received at the beginning an upfront radical complete thymectomy have a better freedom from recurrence without increase in morbidity. Thank you very much for your attention.
Thank you, Piero. Thank you to be extended to the whole faculty. Those were excellent presentations, and I see with Giuseppe that we have a lot of questions. Let's start with Maninder and Nuria. Maninder, when do you think you need a biopsy pre-treatment in these situations?
I think we should biopsy if possible. And the reason is because we know, and I think the next question, which is already there, is about the lymph node dissection. I think it is important for us to know what the tumor is, because the extent of your dissection and particularly the lymph node sampling will probably be dictated by that. At the moment, we really don't know how the end descriptor affects the outcomes, and so people do not really do a systematic lymph node dissection. And there is more and more evidence coming that, especially with the patients with thymic carcinomas, neuroendocrinic thymic tumors, are the ones which where we should be actually going for these lymph nodes, and that will alter the approach you take. So if I have a tumor which is 3 centimeter in size, and I know it is thymoma A, B, or B2, B1 or B2, I probably just proceed with a minimally invasive surgery because I'm confident to take perithymic lymph nodes. But if it's something C or neuroendocrine tumor or B3, then I'll be a little bit more worried about the approach I take, considering that I need to target those lymph nodes. So I will probably advise to have a biopsy unless you are pretty confident this is 2 centimeter, looks like a thymoma, can come out without much problem.
Or unless Nuria can tell us that imaging can replace biopsy in a very reliable way. Nuria, what do you think?
Well, actually, that's what I wanted to stress in my presentation, that current imaging can help us to have a clear idea not only of what is the extension of the disease, but also what type of disease we are moving on. So I would say, on the other side, that I would probably not favor to have a biopsy in most of the cases. Of course, there are certain circumstances in which I would favor to have those, but for most of the patients, I won't.
Okay. Kostas, I have a question for you. And I'm going to open a can of worms here, the lid on a can of worms. And what kind of surgical approach to the thymus? What do you think? Would it change if you know the diagnosis and the type of thymic condition that you're treating?
At the moment, no, because I need to see a little bit more about the end stage where we're getting into. Small tumors that they are fairly well encapsulated. Looking at a CT scan or an MRI scan, I feel confident to take them out with minimal invasive surgery. If when I do the minimal invasive surgery, I see that there is any invasive kind of features, if there are neighbors that I can resect very easily, like a pericardium and put a patch, I will continue with a minimal invasive surgery. If I consider that I strike a possible problem, because I know R0 resection is the most important factor, I will then convert. If I have a large tumor, and the large is not by size only, but it is in topographical size where it is situated in itself. If it looks like the caramelized tumor that essentially melts over the pericardium right and left, I will use a midline incision. If it is a large and a bulky tumor where I think it migrates either on the right or on the left, then I will do a ministanotomy with an anterior approach like a trapdoor, because the most important thing is not being able to see the tumor, but being able to be around the tumor. And you have to make sure that you're not going to cause any injuries to the phrenic nerve, to the recurrent nerve, and to the hilum of the lung. So you need to be able to access the vascular structures. And that's what have been my approach.
Even if you have myasthenia gravis?
Yes, even in cases that I have myasthenia gravis, I think that has been a very questionable issue, whether you sacrifice somebody's phrenic nerve when he's short of breath because of his myasthenia. I think if I know that the tumor is consuming the phrenic nerve and I need to have a clearance, then I will sacrifice, and I'll give him a prophylactic diaphragmatic plication. But I will not leave tumor behind. I don't believe that this is the right thing to do.
Piero, let me ask you one thing. Committed the sin of performing a thymomectomy.
Say again, Gaetano, sorry, didn't understand.
Have you ever committed the sin of performing a thymomectomy instead of a thymectomy?
At the beginning, you mean at the beginning, not at the recurrence, at the beginning? Well, honestly, this is a paper that I've read last month. It's a nice paper with a lot of data, a lot of patients, a lot of numbers. And if you see the curve, there is a small difference, but there is, and it is statistically significant. To be honest, I still commit the sin to do some thymomectomy, so limiting my resection to the tumor, not extending too much to the upper horns or to the phrenic nerve, both sides. And I do this when old patient or patient, of course, without myasthenia gravis, or when you have to elevate the type of surgery you are offering the patient in a way that the trauma, I think, will exceed the benefit of a simple thymomectomy. But again, I think this is something that should be more deeply understand because, of course, the type of surgery you are considering is totally different.
Kostas, are you a sinner too?
I don't do any more thymomectomies. I do thymomectomies and thymectomies, and also if I have a chubby patient that has 0.5 kilogram of prepericardial fat, I take that now as well, and I send it separately. And I know we know from the studies that there are people that they might have ectopic thymic, essentially tumors everywhere in the pericardium. So I have gone from the very simple 20 millimeter, 20 minutes procedure into something more aggressive, in all honesty.
Maninder, what do you think?
I agree with Kostas that I will not do thymomectomy. I will proceed with the radical thymectomy for all the patients, and particularly if there's a myasthenia gravis.
Nuria?
Yeah, I do agree. I do agree too.
Giuseppe, you have questions?
Yes. I have a question for all the speakers. And first of all, do you see any difference in minimally invasive surgery between robotics and video-assisted thoracic surgery? Second question is regarding the topics highlighted by Pier Giorgio. Do you see there is a space for debulking? That means that if you are sure that you will do an air-through resection, you will do or you will not do a non-radical with macroscopic disease resection? So 2 questions for all the speakers. Maninder, can you start?
I don't do robotic surgery, so it's easy for me to say no. So I don't know. But I still go around. I think you gave a fantastic talk in EX, and you were still going around about the lymph node dissection. I'm a little worried that the lymph nodes which are lying in the deeper area, can we approach them with either rats or rats on both the sides? That's the concern I have with the minimally invasive procedures for the large ones.
And regarding the back surgery, do you do?
No, I don't do robotics, so I don't know.
No, the backing, Maninder. The backing in recurrent thymoma.
Oh, yes, we do. We do, and I will do it, yes.
So you think it's okay?
Yeah, it is.
An air through resection of the back, okay.
Yeah.
Nuria.
Okay, I'm not doing the robotics. I'm approaching by back. But in my units, there are another surgeons that they are doing robotics. And actually, I see some advantages of using robotics. Also, I would like to stress the advantage of using endoscopy brain in order to highlight both phrenic nerves. So it is very helpful in order to preserve the nerve. So I would like to highlight this, this feature that can be used both in robotics and then also in VATS approaches. I'm really, well, although I do not do robotics, I see that there is a certain difference approaching lymph nodes stations. So maybe from that point of view, robotics is better from a point of view.
You, Pier Giorgio, you do both, and you Costas too.
In Leeds, we have a robot, and we do both VATS and robotics. I think robotics is having an advantage on thymic resections, essentially, especially when you do have people that they are short, stocky, and they do have a very small anterior mediastinum. You can have a better view when you go around or across the innominate vein and take the draining veins, and can give you actually a complete resection. It aids also in the lymphadenectomy. As far as the debulking is concerned, I'm not very much in favor of messy surgery. If I can do a redo surgery and then I can have the tumor removed, even with positive resection margins, that's fine with me. But if I know that the patient has gross involvement of mediastinal structures, and all I'm going to do is I'm going to give him the blood, sweat, and tears of a redo operation with all sequelae on morbidity and mortality, and then take, let's say, 30% of that tumor or 40%. I'm not believing in this.
And you, Pier Giorgio, the last?
No, well, I have been spending my last 20 years of my career during VATS thymectomy, but as soon as I had the robotic, there's no doubt. I totally agree with Costas. If you have an early stage thymoma, or if you have an hyperplasia, you have to do thymectomy for myasthenia. No doubt, robotic is definitely superior. Easier to do, more precise. No doubt. Superior to, in my opinion, is superior to VATS. In terms of the backing surgery, I think depending on what we are talking, because of course, if you got someone who has got only pleural deposits, pericardial deposit, I mean, it's something that you can do, and sometimes you find millimeter lesion on the lung, on the visceral pleura, and you know that you are not radical at the time, but definitely there is an advantage in terms of survival. If you are talking about large masses invading great vessels or other structure, this is a completely different case. This is a patient that I think that they wouldn't benefit from surgery, but also even from other treatments. So this is my opinion. I will apply the bulking surgery only in really selective cases.
Okay, can we have a very quick telegraphic answer from all the faculty members about subxiphoid approach? Is it going to change the way we do a thymic surgery? Maninder.
Not for me.
No, not for me either. I've tried my hands on it. I still am more comfortable with VATS or maybe bilateral VATS rather than subxiphoid. Yeah, I struggle with it.
I totally agree.
Yeah, it's very obvious what Costas thinks about that. Yeah.
Well, no, I think it's very fashion, but honestly, I don't know if I don't think there is any advantage.
Mm-hmm.
Nuria.
Yeah, I said I totally agree with the rest. I tried and I didn't like it. It did not offer any advantage from the other approaches.
Giuseppe, tell us, what do you think? And then please close.
No, I have no experience with subxiphoid. I've never tried, and I prefer robotic surgery for thymus surgery. That's my opinion, deeply. So I think that we can close the section. Gaetano, do you agree? Or there is any question from you?
No, we have to close. And that was a very interesting session. We need to be really grateful to all the faculty for the unbelievably amazing job they've done. Thank you. And thanks to the attendees and of course the organizer, Federico, great job.
Thank you.
Well done, Federico.
Thank you very much.
Thank you.
Very nice session. Hi, welcome everybody.
Good morning, everybody. I'm very happy to welcome you this morning to the first session of the 8th International Thoracic Oncology Symposium. On behalf of my co-chair, Marco Scarsi, I welcome you to the session about how to optimize resources and deliver excellent patient care in thoracic surgery, a very important topic. And it's my honor to already present to you the first speaker here, Marco Scarsi, who is all well known to everybody here on board. He is the current director of annual meeting of ESTS and the director of the Ospedale San Gerardo in Monza. Good morning, everybody. Thank you, Marco, for starting.
Thank you, Isabel.
So thank you very much for joining on the second day of this 8th International Thoracic Oncology Symposium, which has been developed in cooperation with the European Society of Thoracic Surgeons. As you all know, this is the 8th edition of the course, which I started a few years ago, and I'm really proud that this course now has become a really standalone event and that the European Society accepted to join forces and bring this course to you. So today we're going to discuss a topic that is very close to my heart, and I've been researching and investing some of my time in developing it. So this is how to reduce the mistakes in thoracic surgery. I think this is a particularly interesting topic, especially after the pandemic, where all our working scheme has been altered and we had to still find our feet in this recovery phase. So I have no disclosure relating to this presentation. So the first thing to say is that we all been taught in medical school that the Hippocratic Oath says that primum non nocere, or first do no harm. This is something we all know about it, and it's been kind of hammered into us. But basically, what does it mean? Well, it means in anticipating and reacting properly to an unexpected situation or problem, but also determining what is unacceptable to deliver better care. So what are the mistakes in surgery, and do they happen? Well, yes, they do happen, but they are largely underreported. There are about 200 million surgical procedures performed each year, and mistakes still occur at high rates. Especially now with the development of robotic surgery, where there are some laceration of vascular structure due to perhaps inexperience of the operator. Some of the causes of surgical error, we all know, includes a lack of the adequate surgeon training and education, absence of standardized rules and regulation. This is something really, really important. I work in many hospitals, and I've noticed that once you streamline the procedure and standardize the procedure, the stress level in the operating room and the number of mistakes reduces dramatically. Same applies to the major gap in communication between surgeon and anesthesiology and the nursing staff. In some places, there is really a cultural barrier or a language barrier where basically there is hardly any communication between the teams. In our institution, we always try to bring down this barrier, and we have a system where everybody at any time during the operation can say if they feel that something is wrong. This is because it's been proven that in many critical mistakes, the nurses had the perception that something was wrong, but they were too scared to mention it because of they were fearing a reprimand or being shouted at. So creating a flat structure where everybody can express a doubt or a concern is really important. The same applies to the rush of complete cases. I think surgical planning should really be sensible, and people should take time in making the planning, considering the complexity of the case and also the ability of the operators, of the anesthesiologists, the time needed to change patients. So how do we prevent the mistakes in surgery? I'm sure that if you are asked this question, the first answer that springs to mind is, well, we have a checklist. That is absolutely true. And there is indeed a checklist that is widely used and is compulsory in many healthcare systems. But the main point is how widely adopted is this checklist? Is it really done at the beginning and at the end of each case? And how seriously this process is taken by the healthcare team that is looking after a specific patient in the operating room? Well, I think that when you do it, at least in my experience, the checklist, you enforce it. At the beginning is seen as something that is really a nuisance, as something that is kind of wasting time when you want to get on with the operation. But actually, if done properly, really contribute to strengthen the team relationship, and the operation will then proceed much more smoothly. So what's the extent of the challenge then, of the mistakes in surgery? Well, these are the statistics from the medical literature. 1 out of 10 patients will suffer an adverse effect when receiving hospital care. 7.5% to 10.4% of patients in acute care setting in developed country experience an adverse drug event that results in 140,000 deaths annually in the US alone. At least 1/3 of these events are considered preventable, and 6.3 adverse events effect per 1,000 patient days due to medical device problems are experienced within developing country. So this is really a serious condition. And let's see, apart from the impact on the patient, this has also an impact on the physician, because they are sued for medical mistakes. There is a cost for the institution, and of course, there is a total drive from both the medical practitioner and the hospital to reduce it. So we discuss about the checklist. The checklist is certainly a very important tool, but again, not all checklists can, solve all our problems. And the checklists are a little bit like the Swiss cheese model. So they try to close the holes, but sometimes when there is a chain of events, all the holes, they kind of lined up, and that's when the mistake happens. And this is why we need to build our team to make sure that mistakes are stopped at different level. And the European Society of Thoracic Surgeons really did some work in this. They developed an ESTS checklist, which has been translated in 10 different languages and is specific to thoracic surgery. Because our type of surgery has specific challenges. As you know, there are problems with the airways, with the anticoagulation, and therefore having available a bronchoscope, for example, is very, very important. It could save lives. And you can see the checklist here, which is essentially similar to the WHO checklist, with few items that have been changed to adapt to thoracic surgery. Then there is the checklist deals with the problem that can happen just before the surgery, and then gives an opportunity to discuss the problem after surgery to learn from them. But what about things that happen during surgery? Well, this is there are some case report that describe a little bit the code red that has been developed by Jean-Marc Bast and colleagues to deal with sudden catastrophic bleeding during minimally invasive thoracic surgery. And the way they went about it is a comprehensive simulation program with crisis resource management. In one of my previous hospitals, we developed something very similar in collaboration with the education team, and this has proven to be really, really helpful. One thing that we did, which is similar to what Jean-Marc Bast and colleague did, was to assign a number to the team that was in the operating room. And in case of emergency, each one was doing a specific task, such as call for help, get some blood, get the tools that were necessary, get the thoracotomy tray. And we were constantly simulating throughout the year in specific session catastrophes in the operating room. It was really, really useful. And when the problem arose, then the team was already prepared because it practiced the scenario in a control environment many times. This is what the French team has done, which is similar to our experience. And to be honest, it delivers results. And at the end of the day, if you think are common things such as planning, clamping, compressing, remaining calm, gain proximal control, we all know about that. But the main problem is that when the sudden catastrophe occurs, then nobody's really prepared unless you have practiced the scenario in advance. Another thing that is also been reported in the literature, and I have not experienced this, but is as an excellent idea to further improve what has been done already in my department, is to have a multimedia video-based checklist with a video from the patient and doing the checklist in an electronic format. I think it would really enhance further the benefit of the checklist. And another thing is the closed loop communication. And if we look at this article from Blair Marshall and colleagues, which was a survey among the General Thoracic Surgical Club members, really major mistakes were mostly occurring because of pure communication. Closed loop communication is something that is used in nuclear and the aviation industry, and consisting in stating something and expecting that the person you are addressing repeats the communication back to you, and then you confirm, you close the loop that you understood. This is really important. And another thing that we also experience and is quite good is sterile cockpit environment. That is something that is also practiced in aviation industry, and when a crisis occurs, all the non-essential communication gets stopped, and we only concentrate on the communication that is needed to save the situation and to save the patient. Another thing that is widely discussed is the function of reporting error. Most healthcare providers are deep inside scared of reporting error because they think that there will be an action taken on their license, or they will, you know, get sued or a reprimand. To be honest with you, this is a culture that needs to be changed, and it's actually something that needs to start at the top level of the organization. Most successful organizations have no fear in reporting adverse events, because you know, you should create a non-blaming culture where everybody can learn from mistake and not to repeat again. I'm sure that nobody wants to have a problem in the operating room, but we are still human, so sometimes problems do happen, and that is when you really ought to report it to prevent and share the knowledge. Also, reporting adverse report could also create some problems in the well-being of the surgeon, and that's where your peers can really support you and help you, and you know, get you through this difficult stage in your career. So to conclude, mistakes are recurring and should react to the situation, not to the individual. Human condition cannot be altered. We will do wrong, we will make mistake. However, together as an environment that promotes a safe culture, we can reduce those mistakes to a minimum. Mistakes are never the result of one condition, but it's a chain of events. Therefore, putting in place barrier greatly helps to stop the mistakes from happening. The checklist should be taken seriously, and it's not just ticking the box exercise. Mistakes should be reported because you can learn from those. I understand that this might sound a little bit patronizing and obvious, but actually, if you embrace the culture of reporting at the same time without over-abusing reports, because I work in an institution where every little thing was reported, and eventually reporting things that kind of lost its value because nobody was taking it seriously anymore. So should find a balance, and also discuss with the team, because sometimes, you know, people are simply not aware that something was been wrong, or they've been not involved with the consequences of a mistake. So discussing openly with the team greatly helps. Thank you very much again for joining this event. I really do hope to be able to see you again next year in person. Sorry, the next presentation is from my colleague from ESTS Council, David Healy, and he will talk about improved waiting time performance in diagnostic assessment for lung cancer and patient experience of care. Thank you very much, David, for being here. I appreciate it, and the floor is yours.
You're very welcome to this 8th International European Society of Thoracic Surgery Conference in Surgical Oncology in a virtual forum this year. My name is David Healy, and I'm a surgeon from Dublin in Ireland, and I'm very grateful to the organisers for inviting me to present what I think is an interesting topic, that of improving waiting time performance in diagnostic assessments for lung cancer and patient care experience. First of all, I would like to have no conflict of interest. I think we spend a lot of time as surgeons talking about the high-tech stuff, the robotic surgery, complex operations. We talk about cell biology and immunotherapy. And maybe we forget about the more simple things that do make a big difference to the patient. There's quite a complex logistic patient journey from the point of clinical concern or a screening concern to get to tissue diagnosis, to get staging accurate, to assess the patient, and then ultimately get to definitive treatment. That is a multi-step process, and it takes time. and the cancer doesn't wait. It continues to grow and the clock keeps ticking. And throughout all these multiple steps, there can be multiple doctors involved. There can be different disciplines. And it can be hard sometimes to pull it together. And while it is a team sport, there has to be some leadership that keeps the process moving and keeps a priority on time and focus. From a patient point of view, we know it's important. And as a surgeon, it's important for you too, because you have a professional reputation you'd like to keep up, and patient outcomes are relevant to that. So what I'm going to do today is I'm going to give you my top 10 tips on optimizing that time from presentation to treatment with you. So my first tip is, as a surgeon, you have to rate this as a priority. As I said, we focus on all the high-tech stuff, but don't forget the low-tech logistics. There are real consequences to delays in treatment. We know from screening data that cancers picked up early do better and have better long-term survivorship. And in relation to surgical treatment, more specifically, we know that in cases where there's a long interval between the initial concern in X-ray and the ultimate treatment, that has an impact on 5-year survival. We know that for equivalent clinical stage cancers, patients treated more than 60 days from their original presentation have poorer 5-year survival outcomes compared to patients treated less than 60 days from concern. So this has real patient consequences. So I think for my first tip for this presentation, I'd emphasize that this is a priority for you. It is important. Yes, you are at the tail end of the journey as the surgeon. You're not necessarily the key person doing CT-guided biopsies, but you are impacted by the quality of that process, just as your patient is. So you have to rate it as important, and you have to rate it as part of your problems, and you have to be therefore involved in solutions. My second top tip is collect data, applicable to many aspects of life. Data is power. How long does it really take to get that patient from the start to definitive treatment? If you know that, and if you know where the bottlenecks are, you then can focus on fixing the problems. As a surgeon, you don't have time to do all the surgery and to do this. So you have to recognize that there has to be a system that can do this when you're not around. I would advocate, and I work in a resource-limited system, I would advocate that the problems that lung cancer face are the same as breast cancer, colorectal cancer, renal cancer, and that your hospital, from a cancer point of view, should have a section or department that is focused on data collection, because the needs are very similar across different cell lines. And therefore you can get economies of scale, overlapping technologies, and ultimately you get the data. And if you have an electronic record of that, and if you have your data, you can then do a lot with it. My third key point is set key performance indicators. How do you know how you're doing compared to last year, the year before, unless you have benchmarks to rate yourself against? This also allows you to rate with other centers where you agree a common key performance indicator. One of the points about key performance indicators is they have to be achievable. They can't be utopian ideals. So you've got to think about them and set realistic ones, but they're not set in stone. They can change and evolve. If everyone is reaching them, you could set tighter margins, perhaps. I think it's unrealistic to expect 100% compliance with every key performance indicator, but I think if you're getting 90, 95%, you're doing well, and your system can feel it's getting some of the things right. Again, I work in a resource-tight system, like most of you, I'm sure. And when you have this kind of benchmark, it really helps when you're talking to the decision makers for resource allocation. So this gives you some of the tools to show where you've made improvements with what they've given you before, but also to show where you still need to make some progress and that their money is being focused and not wasted. In an ideal world, there should be some consequences to breaching or failing with KPIs, but it's hard to add further punishment maybe to a system that's struggling, but there should be some consequences or feedback. In the system I work in, we have a national data collection system. For our center, our country, we have 8 centers that are involved in lung cancer diagnostics. And every year we have a meeting where our data is presented to us and we all meet in the room and our performance is compared in front of each other. And this is anonymized, but when you're in that group, you can see for this particular waiting time KPI, most of the centers are doing reasonably well, but you can see some of them aren't. And you don't want to be that group in the room, and you don't want to be embarrassed, but also this helps point out where the problems are. And when you have multiple groups like this, we can compare and we can see how we fix things and ultimately get things better. So you need to set key performance indicators, and it allows comparison. The fourth point I'd make is you have to define your pathway. Every time a patient comes into the system, it shouldn't be reinventing the wheel. Every member of the team should know what the steps are, how to go about them, and it should be very automatic. In our system, from the community, our community doctors are able to access the diagnostic service through an online portal. They all know it, they have a login link. It's common to other elements of our health system, and it gets the ball rolling nice and quickly, and it logs an electronic record from a timing point of view that starts our clock. From there, the different points from clinic to biopsy to PET scans are all very well defined. So if you have that pathway clear, everybody knows what to expect, and it moves along. And when you sit down and think about it, then you can align your different elements so you can get your cytology in the room with EBUS. You can have reserved slots in CT scan. You can have reserved slots in PETs. You could ideally push it to a one-stop clinical. That's quite hard to do with all these different elements, but you can try and get there. My fifth key point is allocate responsibility. Unless there's a named person in charge or something, nobody is in charge. There's an awful lot of different doctors and elements involved in the patient journey from presentation to treatment. And unless there's one person responsible in following that journey from beginning to end, the patient can get lost between and within services. Sometimes the patients don't know who's looking after them. So they need a name of a point of contact to guide them through it. In our system, the allocated responsible person is the respiratory physician at the beginning of the journey, and they hand it over at the treatment decision point. But it doesn't have to be that model. You could have a nursing model, or even you could have a coordinator, wouldn't be a nursing or a medically qualified person. Someone who can just track the patient from the start to finish, interact with the different elements of the system, and be aware and flag problems when someone goes off the beaten track and is delayed. You need to allocate responsibility, and that's a key point. My sixth key point is you do need to allocate to things that you consider important. A biopsy. There are times when people feel that with clinical history and radiological concern, no matter what the biopsy says, you're going to be unhappy with this lesion and you're going to look to take it out. But I would still allocate time to this, even knowing the pressure to get to the finish line. I think it's important for the patient to process the whole experience and the problem, and they need to know, is it benign or is it neoplastic? It can be small cell, and so knowing the cell line is very useful. It's nice to go into an operation with a clear surgical plan that and the patient knows it before they go to sleep, and you know it, rather than relying on frozen section intraoperatively to change course, and the patient goes to sleep not knowing what they're going to wake up with it from a diagnosis or a treatment point of view. And I think from high risk cases, it's very difficult place for surgeons to find themselves in if they do a high risk case and things go poorly and it all turns out to be benign at the end. So that's not really a place you want to be. So while we're all very enthusiastic to get from the beginning to the end, you do have to identify what you think are the key things and the things you need to devote time to. Related to that, my seventh tip is mediastinal staging. This does deserve time, it is very important, but you can make decisions that help you on the way. We don't do mediastinoscopy or EBUS in every single case. If we have a negative PET, we go straight on to surgery. From an EBUS and mediastinoscopy point of view, you do have the options, if the PET is concerning, of having cytology in the room with the EBUS team, or even taking it as far as having the EBUS mediastinoscopy in the same room, where if the EBUS cytology done at the time of the EBUS is negative, you then proceed to do mediastinoscopy in the same sitting. That's quite an efficient system if you can get that up and running. My 8th top tip is make a decision. Surgeons, famously for all the cliches, are people who, if in doubt, do. Other elements of the team, as the cliches go, if in doubt, don't. You're working with a lot of different team members, various levels of training, and it is important that you take all the views together and distill all that. But at the same time, if you want to get somewhere on a journey, you can't wait for the last person to get on the bus, start your journey late, and expect to get to your destination on time. So sometimes you do have to cut to the chase. I think avoiding repetition and avoiding repeating things is a key thing. If a CT biopsy is negative at first time, there isn't a major advantage in repeating it over and over, because the additional yield becomes very, very low. And I think if you had a negative CT biopsy with strong clinical and radiological suspicion, it's reasonable to go ahead and do an excision surgical treatment. My 9th top tip as a surgeon is use your clinic well. You have to assess the fitness of the patient. So you should do that all in your own clinic at the same time. Have slots with pulmonary function tests. Have your anaesthetist involved your clinic to come down and see them. Have your enhanced recovery team program and educate the patient beforehand. All of this can be done in one sitting rather than multiple sittings. Saves the patient travel time. I look after people from a lot of different geography, and also speeds the whole process up. My final tip is focus on complications. You might think it's obvious, and I'm not going to go into the rights and wrongs of all of that. That's different presentation. I'm not going to go into enhanced recovery here, but the key point in this is that unless I get patients home, I can't get the next few patients in. I'm in a resource tight situation, as I'm sure most of you are. I don't have bunk beds in my hospital. So unless I have a good, clean post-op run, minimal complications, and a rapid turnaround, I can't get on to the next person on the list. So you need to focus on the basics and keep air leaks and complications to a minimum, and try and get patients through and home in an efficient manner. I would probably summarize this talk as high-tech versus low-tech. Sometimes we get lost in the excitement and the flash of the high-tech. In my system, the capital cost for a robot is about €2 million plus a reasonable amount of running costs. And the 5-year survival impact on cancer for such an outlay has yet truly to be determined. However, if we spent a generous salary of €50,000 for my world on a coordinator, a fraction the cost of a high-tech robot, and if that coordinator could deliver a reduction in the time from presentation to treatment, that we know would have a solid impact on patient cancer outcomes. When you take a patient through the journey from diagnosis to treatment, you can have impressions and have assumptions about what the patient is experiencing and how good or bad, etc. it is for them. But often the patient wants to please the people looking after them, and during that journey will tell them what they want to hear. So I think you're much better off performing a survey, preferably even anonymously, after treatment, and you'll learn an awful lot from doing that. When the dust settles, you'll get the reflected impression from the patient, and I would encourage you all to do that, and we certainly do that nationally. I put this picture up just to kind of summarize, in many ways, for me, the main points of this talk. I have no financial link with this simple device, but I use it a lot. And every time I use it, I admire its simplicity. And I admire it's so simple, and yet it does exactly what I need it to do. And I think, why didn't I think of that? And I think in regard to this talk, some of the simpler things can actually make a much bigger difference than you think and have a solid impact on patient outcomes. Time and tide wait for no man. Time and cancer wait for no man. The clock is always moving. We need to be conscious of that. And while as a surgeon, you may feel you're at the end of that chain and that journey from presentation, diagnosis, stage into treatment, you do have a role in it, and the consequences of that being done to a poor level impact on the patient and your surgical outcomes. I think as a surgeon, we still retain a role and a burden of leadership in this arena, and we have to be advocates for an efficient journey from presentation to treatment. I hope you've enjoyed this conference, and I hope you continue to enjoy the rest of the day. And thank you very much for engaging with this year, and we hope to see you in person next year.
Thank you, David and Marco, for these two excellent presentations. I think the last picture was a perfect transition to our next talk, who will be given by my colleague from the ESTS Council and professor of the University in Copenhagen, René Peterson. I don't think I have to say much more about him, but he worked a lot on the improvement of minimal invasive surgery for thoracic surgery. And I'm happy to have you here, René. Thank you for joining.
Dear esteemed colleagues, ladies and gentlemen, my name is René Peterson. I'm professor of cardiothoracic surgery at the University Hospital in Copenhagen, Rigshospitalet. First of all, I would like to thank the organizers of this 8th ESTS International Thoracic Oncology Symposium for the kind invitation to this talk. The topic is the role of minimal invasive surgery in a continuing process improvement program for thoracic surgery. These are my disclosures. If we look at the development over the last 3 decades, it's all been about the transition from open thoracotomy to minimal invasive surgery. The development of VATS has been the most important achievement in our specialty for the last 10 years. It took a long time to be implemented in thoracic surgery, and one of the major concerns was a situation like this with an injury to the pulmonary artery, how to manage this without severe morbidity or even mortality to a patient has been an issue that has been discussed. Another issue that has been discussed for years is the oncological safety of a minimal invasive surgery. This is an example of how a lymph node dissection in the right lower lobe lobectomy can be performed, and you can see that all the lymph nodes along the bronchus intermedius, the subcarinal area, the paraesophageal, and the lymph nodes in the inferior ligament can all be removed with this technique. This is the superior mediastinum. You see the azygos vein. To the left you see the trachea. To the right you see the SVC with the phrenic nerve, and in the bottom the pericardium, on the top the subclavian artery with a little fatty tissue where the recurrent nerve swings around the subclavian artery. In Copenhagen we've been using a standardized anterior approach, which is an approach with a utility incision where we pull out the lobe and the specimen at the end of surgery. We put in a port protector there, and then 2 inferior ports, one for the camera and the posterior one for the majority of the staplers. We have the surgeon assisting standing on the same side, looking at the same monitor, working in the same direction, which is beneficial for teaching. Gradually, as VATS has been more and more implemented, the equipment has been undergone a dramatic development. Nowadays we have 3D 4K cameras in Olympus Endosuite. We have advanced instrumentation, advanced energy systems like the LigaSure Ultrasession, staplers like the Signia stapler, and tri-stapling technology, all developments that have made it easier to do VATS and more safe with less air leak. And then of course we need all the dedicated instruments, like you can see in this slide, These are the instruments we use. In Copenhagen, we have now performed close to 4,000 VATS lobectomies overall since the beginning in 1999. And this is by far the largest series in Europe. As you can see in red, that is showing the conversion. So for the last 8-9 years, the conversion rate has been approximately 1%. Whereas in the beginning of the program, the conversion rate was almost 1 out of 3. Looking at the VATS lobectomy rate among all lung cancer patients in our area, which is 2.1 million people uptake, the VATS rate was 93%, and this has been increasing over the years. And you can see there is an annual number of VATS lobectomies, which are approximately 350. Despite Denmark's a small country, we've been lucky to centralize healthcare, and the unit in Copenhagen is quite big. We perform 1,200 major general thoracic procedures per year. The majority are by VATS. 87% of the procedures are performed by VATS. We have spent many years in teaching this approach and this minimal invasive form of lobectomy. We presented the first paper at the Brompton session in 2009, and then the next paper was addressing the topic that when you do primarily VATS, how can you teach next generation who has no experience in open? And this was the next paper we published in this series, and then lastly a perspective paper recommending how to learn the technique. We've had visitor in our theaters for more than a decade now. More than 300 teams have visited us for clinical immersions, and we have proctored several units around the world. We produced, this was a DVD in the times of the DVD, videos of how to do VATS lobectomy, and this is a brand new one which will be released in December on USB and digital with advanced VATS resections. Other units have adopted this technique. This is the Bristol unit, who could show a 3-fold increase by adopting a standardized anterior VATS approach. So it's definitely been an approach for VATS that many surgeons, especially in Europe, have adopted to, and it seems to be easy to teach and easy to learn. So how about the evidence for VATS versus open lobectomy? Is there any evidence? Well, we've been waiting many years for a randomized trial, and this was the first one done by the team of Peter Licht and Morten Bendiksen, and they randomized 100 patients each arm and showed a significant less post-operative pain and better quality of life. The study published in Lancet Oncology, and recently in the UK, led by Eric Lim and a lot of UK colleagues, have conducted this Violet trial with almost 600 patients randomized to either VATS or open, and they just presented the 1-year results at the ASCO meeting this year, and hopefully we will soon see the publication from this study. But what is most interesting, apart from replicating the data, or replicating the data from the Danish study about less pain in the VATS group and shorter lengths of stay, better quality of life, they also showed a significant reduction in adverse events in the VATS arm, which is interesting. We all look forward to read that paper. Potential advantages of VATS versus open are many. Personally, I believe that this one is the most important. We see fewer complications with this approach, and this is something that may translate into survival. You do see intraoperative complications during VATS lobectomy, that's for sure, like any other surgery. We did this analysis, and a publication in the European Journal a couple of years ago in the ESTS minimal invasive interest group, and this publication has a set of recommendations to avoid intraoperative complications during VATS. We published another study based on the ESTS database. This was a propensity score match study showing a lower incidence of complications in VATS versus open, and especially there was significant less major cardiopulmonary complications, and also less death in the VATS arm. We published another study from Copenhagen with 1,379 patients, 785 VATS and 594 thoracotomies, and on multivariate analysis we could show an odds ratio for minor complications of 1.5, which was in favor of VATS, and an odds ratio for major complications of 1.91, which was also in favor of VATS. So significantly fewer complications and less morbidity with a minimal invasive approach. Other surgeons have developed other approaches for minimal invasive surgery. This is the uniportal approach, which has been popularized by Diego Gonzalo Rivas, and who has expertise this approach to very complex surgeries with success. It's maybe expected that using just one port may be less morbid, inducing less pain. However, this randomized study performed by Valerio Perna and colleagues showed very good results in both arms, with a short median in-hospital stay, few complications, and they were not able to show any difference between uniportal and multiports approach. However, there were good results in both arms for sure. This is another approach for minimal invasive surgery is the robotic approach, which is becoming more and more popular, and this was an meta-analysis consisting of 14 papers, and the authors concluded in this meta-analysis that there does not seem to be a significant advantage for an established VATS lobectomy surgeon to transition to robotic based on clinical outcomes. However, having this said, there are a huge development going on within the robotic area. Many companies have got FDA approval for robotic systems, and a lot of the future development within our area must be expected to be on a robotic platform. So I'm sure we've not seen the last paper in this area. But as for now, we must conclude that the major differences are between open and minimal invasive surgery, between the different minimal invasive surgical approaches. If there is any difference, this may be shadowed by the skills of the operating surgeon. Another groundbreaking paper which has come out in this decade is the National Lung Cancer Screening Trial from the United States, a huge study randomizing between CT screening and chest X-ray. They found a significant 20% mortality reduction in lung cancer related mortality, and also, which is very important, 6.8% difference in overall mortality. Then came the Nelson trial, the European trial, with almost 16,000 patients randomized between CT or no control. And they found a 26% reduction in lung cancer death at 10-year follow-up. So there's now substantial evidence for the efficacy of screening programs, and many European countries are now in the process of implementing lung cancer CT screening, and we expect that this will bring a lot of very early stage lung cancers forward, and we need to be prepared to treat them the appropriate way with a minimal invasive approach and with lung sparing surgery. This is another named the trial of the decade in thoracic surgery. It's the JCOG 0802 randomized controlled trial of segmentectomy versus lobectomy in less than 2 centimeter nodules, non-small cell lung cancer. It was designed as a non-inferiority trial, and we finally had the results presented at the JTCVS this year by Hisao Asamura. And despite it was a non-inferiority trial, it actually surprisingly came out with superiority for the segmentectomy arm. And this was despite a higher rate of local recurrence in the segmentectomy arm. The interpretation of these data we are not completely sure about yet. We know that this study is accepted for Lancet and will be published within the next weeks. So we should prepare to do segmentectomy, and we should do it minimal invasive. We have studied the learning curve for VATS lobectomy. Many believe it's around 50 cases, and this is a study studying in the learning curve for segmentectomies, suggesting that it's 84. I think there is no doubt that it is more difficult to perform segmentectomies. This is something that we should practice. This is especially the complex segmentectomies. This is a study showing how the complex and the simple are defined. So mainly it's a lingulectomy, a 6-segmental resection, or the corresponding sparing lobectomies, which are simple, and the rest are complex segmentectomies. They could show that it takes longer time to do complex segmentectomies, but apart from that, there were no difference in surgical outcome. This is the experience from Copenhagen. We've done 280 VATS segmentectomies so far, low conversion rate, which is probably given our experience in VATS lobectomy, and this is a number that we expect to increase dramatically within the next years. One of the tricky things in segmentectomies is to define or to reveal the intersegmental plane clearly. You can use the inflation-deflation method, or you can use ICG, especially for emphysematous patients. ICG has some advantages. We've been using this system for a year, and this is an example of a segmentectomy of 7 and 8 in the right lower lobe, and you can see clearly how the ICG color up the vascularized parts of the lung, so you can see clearly the intersegmental plane, and so you know exactly where to stable when you perform segmentectomy. Parts of the lung, so you can see clearly the intersegmental plane, and so you know exactly where to stable when you perform segmentectomy. This is the ERAS guidelines with 45 ERAS items recommending enhanced recovery in pulmonary resections. We adhere to these guidelines, and this is to show you the VATS ERAS program in Copenhagen. So 93% of all lung cancer patients have a VATS or had a VATS last year. We use a multimodal opioid-sparing analgesia regimen with an intercostal catheter, paravertebral block, routinely 1 chest drain, Sharia 24 with -2 in suction, mobilization on the day of surgery, an aggressive chest drain removal criteria with no fixed upper limit if serous output except chyle or blood, and if air leak is less than 20 milliliters a minute in more than 12 hours, we will remove the chest drain. And most importantly, the rounds are done by surgeons, the operating surgeon every day. This was the surgical outcome I counted for last year, 345 cases. Comorbidity index was a median 2. Length of stay was only median 2. Duration of surgery 99 minutes. And this is despite that we are a teaching hospital, and these 345 VATS lobectomies were performed by more than 10 different surgeons, many of them being trainees. Bleeding 25 milliliter and a conversion rate of only 1%. Thank you very much for your attention.
Thank you very much. It's my pleasure now to introduce the next speaker to you, which is Federico Raveglia. I don't have to introduce as the organizer of this great meeting here today, and we're looking forward to the presentation about lean lobectomy, efficiency improvements in the operating room. Thank you, Federico.
Dear colleagues, good morning from Italy. My name is Federico Raveglia, and I'm a thoracic surgeon from Monza. My presentation is entitled Lean Lobectomy and Improvements in the Operating Room. I have no disclosure. The background of this presentation is simple and is based on 3 points. First, the primary aim of surgeon's effort is always to improve the value of care. Second, higher quality with lower cost is the focus of every healthcare reform. Third, change should not compromise patient safety. Based on the above statement, I'd like to continue by adding that the post-pandemic scenario may lead to the unique opportunity to rethink pathways and management of patients. Indeed, healthcare providers have the opportunity to overcome obsolete models on the way of the general desire to restart normal life. So if the aim is innovation, the key is how to drive this innovation. We have already addressed this topic, addressing the role of standardization in this recent paper. But now, in the next slide, with an eye on the pre-pandemic experience, we are going to address how adopting change-driving methods, such as the Lean Six Sigma, for improvement of quality, cost saving, and better clinical outcomes. And in particular, we will focus our attention on lung lobectomy, since it remains the standard of care in lung cancer treatment. Six Sigma and Lean are two prominent quality improvement methodologies that have been validated across several areas of healthcare. I invite you to consider this paper. It is a review assessing the literature with regard to the use and utility of Lean and Six Sigma methodologies in surgery. Authors selected 23 suitable papers and concluded that these methodologies have the potential to produce clinically significant improvement for surgical patients. But what Lean and Six Sigma consist of? The Lean process strategy was aimed to manufacturing waste elimination. Lean has been applied also in customer and financial services, and also to several aspects of healthcare, including finance, inventory management, information processing, outpatient clinics, and inpatient setting. And to summarize, Lean focuses on reducing wasteful or non-value added steps in a process. Instead, Six Sigma methodology was aimed to improve the quality by identifying and correcting the causes of errors. Six Sigma attempts to drive production failures to 6 standard deviations for the mean, or 3.4 defects for 1 million products. It's tried to achieve a negligible number of defects corresponding to the probability associated with a correct Six Sigma value for the normal curve. And very important, the Six Sigma level is not possible in biological systems, but is applicable to repetitive procedures such as surgery. More in detail, from a statistical point of view, the etymology is based on the Greek symbol sigma, a statistical term for measuring process deviation from the process mean. Six Sigma comes from the bell curve used in statistics, where 1 sigma symbolizes a single standard deviation from the mean. If the process has 6 sigma, 3 above and 3 below, the defect rate is classified as extremely low. The higher the standard deviation, the higher is the spread of values encountered. So processes where the mean is minimum 6 sigma away from the closest specification limit are aimed at 6 sigma. Now that we have introduced these two methodologies, next step is to understand their role in the healthcare management. In this paper, authors started from Lean and Six Sigma characteristics, and they concluded that in many quality improvement projects, these different tools are complementary, which has led to merging them into a single strategy that is called Lean Six Sigma methodology. But how does it work? The Lean Six Sigma offers the roadmap as an improvement tools. And this roadmap consists of 5 points: define, measure, analyze, improve, and control. The define phase concerns the definition of the problem to be solved. Measure, aim to quantify the current process performance. Appropriate measurements are needed. The so-called critical to quality indicators in Lean Six Sigma terms. Analyze. The aim of the analyze phase is to arrive to a data-based diagnosis of the current process performance. Improve. After the process is diagnosed, the project team determines objective for intervention to eliminate waste and to reduce wasting times. And finally, control. The new process is actively monitored to ensure that better results are retained. Today, the use of Lean Six Sigma methodology in the healthcare arena has focused mainly on business operation and management. And the clinical use of Lean Six Sigma methodology has focused on efficiency outcomes such as reducing the length of hospital stay in stroke patients, but application of Lean Six Sigma corporate improvement method was successfully used to improve clinical outcomes and also to reduce surgical complication in repetitive procedures. In the next slide, we will focus on 3 recent papers from literature about lean lobectomy and how the procedure lobectomy could be improved by the use of this tool. The first paper is from a Spanish group. Their aim was to improve hospital finances while increasing patient-related outcomes. The study was developed on a 10-year period, divided in 3 steps. A baseline before lean application. The second step was the lean implementation, and the last, the full implementation period. Data included patient demographics, clinical presentation, radiologic findings, pathological report, type of surgical approach, open versus VATS, complication, length of stay, length of chest tube drainage, mortality, surgical time, a 30-day readmission. According to Lean Roadmap, authors assembled a multidisciplinary team composed by thoracic surgeons, nurses, scrub nurses, pharmacists, administrative and information technology staff. Then the team identified a subset of activities within the value streaming map. These activities were pre-operative evaluation, admission and business office, surgical scheduling, surgical procedure, hospital care, discharge, and follow-up. Processes were then mapped, and each process step was evaluated on whether it added value or not to the process itself. By the use of tools such as root cause analysis and plan, do, check, act, improvements were identified and introduced. By the use of key performance indicators, improvements were measured, and in case of significant result, a new standard was established. And which improvements have been identified? As concerning pre-operative evaluation, a nurse coordinator was selected to follow the patient all along the process. Special emphasis was placed on post-operative course. It was explained to every patient that there was a 1 in 10 probability of having a leak requiring a discharge with an Heimlich valve. Concerning surgical scheduling, real OR occupation was measured and the time needs of the surgical teams was inquired. Fixed surgical blocks were assigned to each one of the surgical teams. Surgical times were strictly recorded in the operative report by the circulating nurse. As concerning surgical procedure, some steps were eliminated, like the usage of the axillary roll, the placement of the central line, epidural catheter, and urinary catheter. The minimally invasive approach was intended to be used more often with early-stage lung cancer, and the use of ultrasonic scalpel was incorporated. Teams were reassigned to each surgical team and is regular anesthesiology and OR staff. As concerning hospital care, pain management was standardized and communicated to each one of the hospital floors where thoracic surgery patients spend their recovery. The use of epidural catheters was discontinued. Routine daily chest X-ray were eliminated, Air leaks that were apparent on second post-operative day were dealt with an Heimlich valve. And here the result. Authors describe that they were able to obtain significant reduction of hospital stay and significant direct contribution margin. The second paper is about how to streamline VATS lobectomy process. Authors sought to use system process improvement to streamline VATS lobectomies at their institution and targeted cost drivers to optimize quality of care and minimize overuse of resources. According to lean criteria, they perform retrospective review of postoperative practice for patients undergoing VATS lobectomy, establish a value stream map, use a granular cost database, and perform real-time analysis. Then they identified cost drivers, practice variability, and rate seeking by the means of an outcomes database. Lastly, they implemented process redesign with constant review and formal value stream reanalysis at 6 month intervals over a 2-year period. In the picture on your left, you can see the two processes. The upper one is the process improvement method before lean introduction, and the lower one is after lean introduction. And as you can see, many steps were or have been eliminated. In particular, they obtain an overall 1,087% reduction of time in the operating room, fewer chest X-ray per patient, laboratory draws, and consultation as well. 234% reduction in mean length of stay and an overall cost reduction of 40%. No detrimental effect on patient outcomes. That's the point. This is most important point. Pulmonary complication, cardiac complication, and readmission rates all decreased. The last paper addressed pre-incision time. Although surgeons spend many hours in or around the operating room, only a fraction is spent operating. It's estimated that 1 minute in the operating room costs between $22 and $133 in the United States. Patient preparation for pulmonary resection routinely includes bean bags, axillary rolls, arm boards, arterial catheters, and urinary catheters. Many still use thoracic epidurals and central catheters because they are considered the standard of care. Adopting lean tools, already described in the previous slide, authors introduced the following improvements. Axillary rolls, arm boards, and bean bags have been eliminated once again. Monitoring devices were slowly eliminated. Central catheters decreased from 75% to 0% of patients. Epidural from 84 to 3% of patients. Arterial catheters from 93 to 4. Foley catheters were reduced from 99% to 11%. A protocol for insertion of double lumen endotracheal tube was established, and time decreased, as you can see. At the end of this process, time between operating room entry and incision decreased from a mean of 64 minutes, about an hour, to 37 minutes, about half an hour. And outcomes improved. mortality decreased from 3.2 to 0.2, and measured morbidity decreased from 50% to 5%. And that was brilliant. Just few minutes more to underline that lean has been applied also by other services than surgery. Here we see its application in endotracheal tube placement and placement teaching. Introducing monitor and flexible bronchoscope, authors were able to obtain a median time for double lumen placement decreasement from 13 minutes to 5 minutes. And anesthesia resident present for 76% of operation were able to place the tube independently 80% of time more than before, and there were no airway perforation. So at the end of this long and I hope not so boring presentation, take-home messages are the following. Efforts for hospital-wide solutions that allow to maximize efficiency and timelines of treatment are mandatory in thoracic surgery after pandemic. Stakeholders' aim is to improve value in healthcare systems. Value is the result of a comparison between clinical outcomes and cost. Non-value added steps are a hidden source of cost, always. Every process should be mapped, reviewed, and improved with the objective of providing better outcomes while reducing cost. And finally, the lean methodology provides an effective framework to address all the above goals. Thank you very much for your attention and see you soon here in Monza, Italy. Goodbye.
Thank you, Federico, for this excellent talk. This was really very interesting. And I'm happy to introduce to you the next speaker, Dr. Sridhar Rathinam. It's my pleasure to introduce him. He's a consultant thoracic surgeon at the University Hospitals of Leicester. And he's the chair of the Cardiothoracic Surgical Specialty Board of the Royal College of Surgeons of Edinburgh. And last but not least, also a society colleague because he's the thoracic surgery in Great Britain and Ireland. Welcome to this interesting session, and we're curious to hear your talk.
Good morning, everybody. I've been asked to talk about the impact of the surgeon's physical, mental, and emotional state on patient outcomes and excellence. What we'll try to explore in the next 15 to 20 minutes is the surgeon persona, the impact of workload on surgeons, and the impact of the surgeon's state on outcomes, and finally finish off with some fitness and mindfulness. Surgery is a risky business. We all know we have to strike the right balance in reducing harm as well as pursuing excellence. The surgeon is at the forefront, and any outcome is always apportioned to the surgeon. Although we work as a team, we are seen as team leaders. This is a newspaper article when England published surgeon outcome data. This is Shushruta, who was the father of surgery. But not only was he a clever physician and a technician, he also was a yogi and a mindfulness expert. How do people see surgeons? Surgeons are a constructed identity. People expect us to be knowledgeable, very confident, decisive, bordering on arrogance. We're seen as Superman and superheroes. However, we are only human after all. We have a definitive cognitive capacity, and we always are under pressure to measure up, and we have the primal fear ticking constantly. And we use our cognitive bias codex. What should we remember? How do we act fast? This doesn't have enough meaning and too much information. We process, prioritize, and deliver. And all of that takes a toll on the surgeon. We always have to perform to win. Research states a training penalty shootout conversion is 85%. If it is taken with a view to winning, it's 93. However, if it's a shot, not to lose for your team, it's 63. Every day we scrub up, we are not to lose mode because there is a life at stake. The performance and stress arousal makes it a good challenge, and we start performing well once you have an optimal stress and arousal. However, once that gets very significantly high, it actually is a deterrent in performance. And the reason for that is we all have a finite capacity, and we have an attention threshold wherein some primary activities are used and the spare capacity is for the rest. A novice takes much more time and capacity to do a task as opposed to an expert. However, when it comes to critical steps or critical events, we need to learn to slow down and have an effortful act, which will be using more primary activity and delivering better outcome. So we need to move from automatic to an effortful state. If not, we end up with surgical adverse events. The reason for that is we have a finite cognitive memory. The working memory helps us make decisions and subject to interference, like stress, fatigue, workload, hunger, and all of that shrinks the working memory, and we then make bad decisions or not able to make decisions. Being a surgeon, you expect to have high values. You're a destiny community. Your requirements are to be an absolute rock. There's an expectation for you to do everything possible, quick, decisive, and almost bordering on perfection in individual services. However, we are vulnerable too. We dare not express our fragility in public. We risk criticism. So there is a lot of internalization of what we go through to put on the persona. And when things happen, and when adverse effect or mortality, there is initially an acceptance, but there are consequences which can be psychological, physiological, cognitive, emotional, and professional. And we need to have coping strategies, which may be personal, seeking help from your support group, and not but not the least, if need be, external support. Because surgeons are vulnerable. We are physicians and human, and we need to have these integrated into the curriculum to create an emotional intelligence to build our team, which delivers. The complexity of surgical decision-making, again, has a toll on the surgeon. If all the decisions are about decisions, which is to the standard with the guidelines, it's fine. But when you start making unavowed decisions, which is in an undeclared principle based on pressures, or disavowed, where you're doing it for your or institutional best interest rather than the patient's interest, there is impact on the surgeon. Well-being is more than health and housing. It's a quality of personal relationships, the positive emotions and a sense of resilience and realization of their potential and overall satisfaction in life. Our life has various events, and there is always a response within various time periods. And this can be a seamless resolution. The outcome is good. However, sometimes it is tortuous before we reach an outcome. And there are various reciprocal domains which keep the physician and the surgeon well. One is individual, personal motivation, resilience, the institutional culture, as well as systems in place to support. One has to find a niche of being emotional well-being. It could be yoga, it could be mindfulness, it could be physical activity, from golf to cycling. This is my good friend Meninda Calcutt, who ticks all boxes. So it's a physically strenuous cycling ride from Land's End to John O'Groat, supported by his loving wife, and a strategy and mental strength to endure the trip. We need to have psychological safety, which is creating an environment for a safe conflict when we work at home where you can have a healthy give and take and be open rather than tiptoeing and avoiding issues. How does it improve patient outcomes? When there is a psychological safety in the team, then outcomes are better. There are 3 examples here. In a cancer team, quality assurance, places where there was low psychological safety had silent walkarounds, whereas places with high psychological safety were able to unpick problems and prevent adverse events. The same with the study from Belgium, wherein high standards and low psychological safety meant more errors and vice versa. Looking at cancer in 137 acute trusts, revealed openness and a better psychological safety translated into lower mortality. And this is based on our behaviors. It's on the 4 pillars of trust, humility, curiosity, and attitude. We all have an emotional bucket which we keep filling with our workload, our stress, the conflict, deadlines, unclear expectations, and all of that have an effect on our activities. So you need to make sure that your emotional bucket is empty, especially when you're embarking on a big operation, because it has an impact. If we're not careful, this leads to burnout, which has the various adverse effects of lost relationships, depression, suicidal tendency, alcohol, and professionally, care drops, your patient satisfaction goes down, and you start losing team. In the United States, physician burnout costs $4.6 billion, and of which 37% was from surgeons, and more so in younger surgeons. And how does it affect the workload setting, the demand, the work environment, all lead to stress? Added to that is the personality and psychological factors, compounding things to lead to burnout, causing physical and mental strain to the surgeon. Looking at burnout syndromes in surgeon, a systematic review found out younger age and females extended to be associated with high level of burnout. Senior trainees or consultants had less. Certain personality types were less likely to burn out, and mentorship reduced the level of burnout. This was surgical specialties alone, wherein surgical trainees again had the highest prevalence of burnout and younger age and lower clinical pay. However, it also showed if they were in a relationship or married, there was a protective effect against burnout. Do all of these have an impact on the outcomes? To start with, surgical attitude may actually have an impact on outcomes. Arrogance got more pilots into trouble than faulty equipment, said Chuck Yeager. And the attitude is a personal motivational predisposition to respond to persons, situations, or events in a given manner. And this does influence on how a person makes decisions. There are hazardous attitudes within surgeons. You could be macho, you could be impulsive, you're a resigned individual, you're a worrier, too much self-confidence, or you're anti-authority. We need to identify antidotes to avoid the impact. So you may have to get the impulsive surgeon to slow down and ensure the macho surgeon doesn't take too many foolish chances, because all of this has an adverse effect on patient outcomes. Does surgeons' leave and absence have an impact on patient outcomes? This was a study from Papworth Hospital where they looked at cardiac surgical patients and to explore if surgeon leave had an impact. Now, there was a tendency of better surgical outcomes. The patients operated immediately after the consultant returned. But there was an element of higher mortality prior to the leave, and this was thought to be due to the complex cases or urgent cases getting done. However, this did not achieve any statistical significance. Does a surgeon's birthday have an impact on patient mortality? This was an American study wherein they looked at a large cohort. Nearly 2,000 patients had their procedures performed on the surgeon's birthday. The 30-day mortality was higher, and even the adjusted mortality rate was higher. So do surgeons get distracted on their birthday? Does it have an impact? We never know. Sleep. We all need sleep to keep taking over, and it becomes more important as we grow gray and old. What is the impact of sleep? So cardiothoracic surgery, does sleep deprivation have an impact? And they were a systematic best evidence review, which looked at various studies, and there was little direct evidence demonstrating the effect of sleep deprivation in cardiothoracic surgeons' morbidity or mortality. However, non-cardiothoracic studies revealed it can have a significant impact. Effects of sleep deprivation are quick and marked with a resultant fall in performance and an increased risk of error. And as clinicians, we always neglect our own needs and health. We do not drink, we do not eat, we put up a brave face after a difficult night's on call and get on with our work. But this may have an impact, and this has to be taken into consideration. And to finish off, we need to be fit, and that could be in your chosen way. It could be running, it could be walking, cycling, gym, golf, whatever, but we need to keep our body active and mind clear. I'm going to just give you some insight into some fantastic work done by Professor Carter Labaras in the University of California, San Francisco, where they created an enhanced stress resilience training to their residents and their teams, which incorporated interoception, which is to be aware of your own body and mind, emotional regulation, which was arousal regulation, and finally metacognition, which is self-regulated learning. They had 5 weekly 1-hour class, graded daily practice and booster sessions. There was a training manual and a video component. It enabled people to explore their own breath, their body. Even if doing a wall round, they wanted to be walking firmly, feeling the ground under them, shoulders swinging. So it was a combination of physical and emotional and mental training. Now, it revealed people who had ESRT training were more mindful. Their global executive function was better than control. Likewise, we all respond to stress with pro-inflammatory and beta-adrenergic stimulants in our body. And there was a 1.5 times increase in the controls when there was a stimulus. However, with the ESRT trained cohort, there was a 50% reduction. So there was a protective effect against stress. They were better in comparison to controls in terms of higher mindfulness, reducing total burnout, stress, anxiety, and depression. But the most important aspect came when the same group looked at the stress during the pandemic. And surprisingly, one cohort had the lowest level of anxiety of all of them. And it appears they were the postgraduate trainees who've been part of the ESRT training from 2006. So they were much more in control and calm in the face of a pandemic. Why does this all happen? Because all our positive emotions and emotional resilience give us joy, love, contentment, and happiness. This broadens our inventory and thoughts and action, leading on to developing physical, mental, and social resources, transforming into advanced personal growth, and creates a more positive emotion. So it is an upward spiral of positive emotions. Let's not forget, we are all getting old. So the eyesight's failing, the back's hurting, we cannot do the long hours which we did. There's on-call challenges. Unless you're careful, there is a resilience issue as well. And we also start trending to go into boredom because you're doing the same thing over and over again and you become an expert. There is no challenge to push us. So we need to take this into consideration and try. In the UK, there is a move to have senior surgeons of the on-call rota, keeping them in a mentoring role, using them for education and standardization, and offering them reasonable lists with them being available and able to help junior colleagues during the complex elements of the operation rather than doing the whole procedures. Because the learning curve starts off very confidently saying, I know it all. And then we realize there is more to this than what we thought. It is daunting sometimes, but once you become an expert, you realize how complicated it is and how well you can deliver it. We all find different ways to keep us enhanced. This is a platform which my wife and I created during the pandemic when people were all stuck at home. Chennai in Tamil means the courtyard where you sit and chat with your friends. So this was a virtual web, and we used to have various guests to have interactive sessions to keep people entertained. And it brought us new aspects. It kept us sane. And this is Maninder Kalkat sharing his cycling journeys on the platform. There's always going to be challenges, and our outcomes will always have an impact on our patients. But the key points are, yes, surgeons are greater than life, but we're human after all. And the impact of our workload and lifestyle may lead to burnout, and we need to be able to deal with it. And what happens in our lives will have an impact on our patient outcomes. So we have to be careful and look after ourselves for our patients. The surgeon has to heal himself or herself for the protection of our patients. We need to find a silver lining in all the dark clouds. Thank you.
Well, we can go on now with the last presentation. It's my pleasure to introduce Dr. Luke Howard, consultant pulmonologist from the Imperial College in London, UK. And his presentation is entitled "Fit for Surgery, Where do we draw the line?" Sorry. Please go on.
Hello, and my name is Luke Howard. I'm a consultant pulmonologist at Hammersmith Hospital in London, and also based at the National Heart and Lung Institute at Imperial College, London. Thank you very much for asking me to talk on this subject of fitness for surgery. Where do we draw the line? In fact, quite a difficult subject to talk to. I don't have any disclosures other than to say that I'm not a lung cancer doctor. I'm obviously not a thoracic surgeon. I'm an exercise physiologist. So I'm interested in how we look at patients in a preoperative, in terms of their preoperative status and their physiology, and how this may impact on perioperative morbidity and mortality, purely from a physiological perspective. What I'm not going to do is present to you a series of slides on Kaplan-Meier curves. There's a couple in there, but mainly to talk to you a little bit about physiology but perhaps from a slightly more philosophical perspective about how to assess risk and whether it is indeed even possible to draw the line. And hopefully at the end of this, you'll realize that that line is, there are some lines you can trust, but otherwise there's quite a big gray area which still relies on that really important thing, which is physician or surgeon interaction with patient, assessment of risk and discussion around consent. So one of the philosophical things to consider is, what is the outcome if you do nothing? And there are certain things that go into this really is, should you really be prepared to accept and take on a risk? There are many patients who might say to you, I don't care if I'm going to die, I just want to have this surgery done anyway. Is that a fair thing to put on a surgical team, and in particular on the lead surgeon? Who is it to say what kind of risk is indeed acceptable? Is that a 5% risk of death, or a 10% or 20%? It's very, very hard to say. What are the implications for a bad outcome? That could be in terms of your job, for example, in terms of your outcomes, or something as important as your mental health. And also, of course, one has to consider if there's a reasonable alternative. Then on the other side, we're trying to think, what are we trying to predict? Risk of what? Morbidity, mortality, what the function might be of the patient after you've taken a significant portion of their lung out. And then finally, how can you even predict a risk? A significant risk which is binary, such as life or death, when the chances are so small. How can you really get a test that's going to tell you what's going to happen after you remove a portion of lung, given that there are so many unpredictable things that can happen? So that's the backdrop really to this, and exactly why it's so hard to draw a line. One of the major things to consider from my perspective when interpreting exercise physiology is just how different lung cancer surgery is from other types of surgery. The obvious difference here is that when you remove a piece of lung, generally speaking, you're going to worsen cardiopulmonary function, unless of course you're removing some useless lung, which will potentially result in lung volume reduction surgery. On the other hand, when you're assessing somebody for cardiac surgery, one of the factors to consider is that you're very likely to improve function following surgery. And then with GI or hepatobiliary, then hopefully nothing is particularly going to change. So this is a thing we're really going to focus on here, which is the guideline from 2009 on the assessment of risk prior to surgery. And I'll walk through this as we go through the presentation. Just important to say that really this was published in 2009, and I'm not aware of any significant updates since then, because there hasn't really been any more data. And I think this reflects that this is a very sensible way of approaching what is quite a tricky situation. One of the important things in the guideline is the focus on peak VO2 or VO2 max. Why is that? Well, in my view, maximal oxygen consumption is the single best global measure of assessing the overall integrity of the cardiopulmonary system. And here I've got the cogs connecting with each other, showing how what happens at the muscular level in cardiopulmonary exercise testing drives oxygen flow to the muscle and CO2 flow away, and then the lungs taking up oxygen and expiring CO2. This is reflected in the surgical guidelines with the following statement, that VO2 peak measured during an incremental exercise test on a treadmill or bicycle should be regarded as the most important parameter to consider as a measure of exercise capacity and is highly predictive of post-operative complications. Why is VO2 important? Well, let's look at a trajectory, an imagined trajectory of VO2 around the time of surgery. This is what we might expect in an uncomplicated procedure, a rise in oxygen demand. But of course, we have to be prepared for the eventuality that following surgery, there may be a complication which might require an increase in oxygen consumption. Now, I read into this a few years ago to try and find out what kind of oxygen consumption might be relevant around the time of say, for example, significant sepsis following surgery. And in my reading, I came up with a number of 800 mils per minute. If you consider that a patient might be an average of 70 to 80 kilos, this roughly equates to 10 mils per minute per kilo. So therefore, what we're talking about is the ability to deliver that amount of oxygen so that the body can consume 10 mils per minute per kilo. And that's quite nicely borne out with the guidelines. And so it's always nice when things add up and make sense. When we look at what happens in the normal situation, then it looks something like this. That there's an increase in cardiac output, and when you get to peak cardiac output, we have at that stage the peak oxygen consumption. That's a normal situation. And in this same situation, ventilation will rise, but there is usually a significant ventilatory reserve, or sometimes we call it breathing reserve at peak. When you have a situation of ventilatory limitation, so for example, many of the patients undergoing thoracic surgery may have such severe lung disease that it's not the heart that limits them in terms of peak exercise, but it's the lungs. So you get to a peak ventilation, which may be between 35 or 40 times your FFV1, depending on who you listen to, and that's what stops you. And you have still a significant amount of cardiac output reserve remaining. So we've got these two situations of circulatory limitation and ventilatory limitation, with this perhaps being most common in thoracic patients. And the critical thing here is that the peak VO2 that is measured on the exercise test, whether it be ventilatory or circulatory limited, has to be above this peak here. Otherwise, if it's here, for example, below this peak, then the chances of surviving a significant perioperative complication are very small indeed. So when we now look at the current algorithm, how does it start off? Well, it starts off with a cardiac assessment. So if on the basis of clinical history and examination, there is very unlikely to be any significant cardiac disease, then we can assume that there's going to be no significant additional circulatory limitation over and above what is normal. So the heart and the cardiovascular system is working normally. That means we can then focus on the lung function, because that's the thing that's probably going to be impaired in these situations. If by measuring FEV1 and DLCO, we find that they are both within the normal range, so above 80%, then it's very unlikely that the patient is going to suffer from significant ventilatory limitation. We'll have situation normal. Maximum cardiac output is what limits VO2, and there will be no obvious ventilatory limitation. In other words, we've got room to play with. Now, if, on the other hand, there is ventilatory limitation because the FEV1 is low or the DLCO is low, then what does the situation look like? It looks something like this. We have a patient pre-operatively who reaches their maximum ventilatory capacity at the same time they reach their peak VO2. What we then do is we remove some lung, and therefore their peak VO2 will necessarily drop. And this will then obviously impact on the potential risk of surgery. So that's the FEV1. What about the DLCO? Well, why is this important? Well, DLCO, if we reciprocate it and we look at overall conductance, then it's a sum of the capillary blood volume, which will be decreased, for example, in diseases such as emphysema, where there is alveolar capillary destruction, and the diffusion across the alveolar capillary membrane. So in this situation, ventilation becomes inefficient. So for the same VO2, ventilation is higher, is further limits where peak VO2 occurs, and so we have a further reduction. That's why FEV1 and DLCO are both important, because they worsen ventilatory efficiency as well as the ventilatory pump capacity. So coming back to our algorithm, if we have the FEV1 or DLCO is less than 80%, then proceeding to cardiopulmonary exercise testing, if we find that the peak VO2 is more than 20 mils per kilogram per minute, then we on fairly sure ground that there will not be a significant problem. Why is that? Well, I take you back to the fact that if you remove roughly half the lung capacity, you'll get down to about 10 mils per kilo per minute at maximum. And this is sufficient to get through most forms of complications. Therefore, with these values, you can resect up to pneumonectomy. So there seems to be a clear line that you can draw there based not only on an evidence, but also on working back to basic principles. There is a bit of a problem with this value of 20 mils per kilo, of course, that say, for example, if we look at normal ranges. So here we've got men on the top graph, and we've got women on the bottom graph, and these are predicted VO2 peak values. And we have age categories on the x-axis. Now, if I just take you to the example of women, I've drawn a line across from 20 mils per kilo. The solid lines are patients with a BMI of less than 25, or normal subjects, should I say, and the dotted lines a BMI of more than 25. What you can see is that once you start getting over the age of 64, 20 mils per kilo is normal. So you may have somebody who is less than 75% predicted, but still in the normal range. So are you going to be turning down somebody with completely normal physiology who has a peak VO2 of, say, for example, 16 or 50 mils per kilo with a peak VO2 that may be 70% predicted? So it is tricky, I think. But of course, if you take an extreme, somebody who's aged 85, who has a peak VO2 of, say, 13 mils per kilo, which might be close to normal, well, then, of course, those values would suggest the absolute values that the patient's at higher risk, but of course they are, they're 85. So I think the absolute value does need to be called into question, as well as the percent predicted, and other factors such as age need to be brought into the equation. But of course, you're very good at generally doing that when assessing risk of surgery. But the upper bound of 20 seems to be acceptable. What about the lower bound? Peak VO2 of less than 10 mils per kilo per minute, or 35% predicted. Well, I think I've demonstrated already that this seems to make sound sense, and therefore I think you can draw a line at this level. It may be that if your patient has significant cardiovascular limitation and they're not limited from a ventilatory capacity, that some prehabilitation may improve overall cardiovascular function and get a patient into a place where they may be considered for surgery. What about this horrible grey zone in the middle, of course, where you're between 10 and 20 mils per kilo? Well, here you then need to look at the impact of surgery removing lung on the peak VO2 now, or on lung function. So we do have this middle step here of looking to see whether the predicted post-operative FEV1 or DLCO is over 30%, and if it is, then it's likely, therefore, that you're going to be able to resect up to the calculated extent, and I'll talk through how this is done. Really what this is getting at, though, and I don't know necessarily why you don't jump straight to this step, is what's the predicted peak VO2 likely to be like after you remove some of the lung? Because what we're trying to do is look to see what the impact of removing some lung is on this VO2. So how do we look at predicting post-operative function? Well, in the case of lobectomy, you can multiply the preoperative FEV1 by the remaining lung that is going to be left, and what you take into consideration is the number of unobstructed segments to be resected. So if you're removing the right lower lobe, for example, and you're taking out 5 segments, and the total number of unobstructed segments, say for example, is 19, then you're going to be left with 14/19 of your FEV1, and you can do this for DLCO and peak VO2. But that is assuming that your peak VO2 is primarily already limited by lung function, which it may not be. So you may be overestimating the risk, overestimating the reduction in peak VO2 post-op. For pneumonectomy, the preferred suggestion, at least in the 2009 guidelines, was taking away the fraction of total perfusion as assessed by VQ scanning. And in the guidelines suggested you can either do V or you can do Q, but you don't need to do both. So how much evidence is this based on? Well, there are 2 papers that went into the guideline. This one was published just a couple of years before the guideline and looked at a very similar algorithm to the one I've already shown you. So I'm not going to go through it in detail because it's effectively almost the same. And they had about 100 patients who were unresectable and 200 patients who were resectable. And when they looked at the outcomes, in this study, they showed that patients who didn't undergo surgery had a worse survival than those who did undergo surgery, showing that effectively by selecting patients out with these criteria that you can improve outcomes, or looking at it the other way around, you don't, by using these criteria, end up with the same outcomes. In other words, you're not operating on people with excessive high risk and causing early mortality. So it does seem to at least work in that regard. Another study that was published at the same time as the guidelines, so these were in press at the time the guidelines were published, Brunelli as the lead author, went through a very similar process of assessing cardiological function, and if cardiological function was stable, then undergoing FEV1, DLCO, and CPET testing, and if patients had these low barriers of peak VO2 of 10 mils per kilo with low predicted post-op FEV1 and DLCO, then they were barred from lobectomy or pneumonectomy. But if they were in this mid-zone, then if the peak VO2 was greater than 10 mils per kilo, so this is actual peak VO2 and not predicted, resection went ahead as planned. And what they showed was that with a cutoff of a VO2 of 12 mils per kilo, this picked out a high risk of mortality in the group of patients that were operated upon. And you can see, looking across these categories of VO2 of 12, 12 to 15, 15 to 20, and above 20, there is a decreasing risk of total morbidity, which is split here into cardiac and pulmonary morbidity. So it does seem to work in the real world. Maybe we can try and predict post-operative VO2 max better. So for example, here's a patient whose ventilatory function is not limiting them at peak exercise. They still have a bit of breathing reserve. So in other words, if you were just going to take their ventilatory function down from here to here, you may not be impacting on their post-operative VO2. But if you're taking it down a little bit further, as I've illustrated here on the right, then you will. But what you can't say is that you can necessarily ascribe a proportional reduction in FEV1 all the way through to VO2 by looking at the number of segments removed. So we might be able to predict it better, and that's why I think an open discussion between the physiologist and the surgical team can be helpful. But how much will it help? Well, the problem is that you can't suddenly cross a magic threshold and your risk of mortality shoot up significantly, because there are so many other factors involved. So it's a bit difficult to say that if by being more precise, we can be more accurate. And so I think one does need to remember this is quite nuanced. So is there a bottom line? Yes, there's a bottom line. I think we're happy with 10 mils per kilo as the bottom line. Is there a top line? Yes, 20 mils per kilo seems to be a top line. What's the bottom line overall of the presentation? Well, I think an algorithm can be used to justify your decision if that's what you want to do. It's always helpful to be able to sit down and show an internationally recognized algorithm to back up your decisions. Cardiopulmonary exercise testing, I think, is more nuanced than just looking at a VO2 max, and I think very useful to guide consent and inform patients who might be going into surgery with a slightly higher risk of this very risk. So just to round up, I think there are these 4 bins that I've put these decisions into. The first starts with you, the surgeon, whether you have a clear view on whether a patient is operable or inoperable, or in the case whether it's unclear, then patient consideration does come into account. A patient may be very keen to operate or not operate, or they may need some guidance. Looking at integrating your view with the patient's view with the algorithm can further delineate decision making. And then there is, of course, the gray zone where the algorithm can help. And you can sit down with your patient and either hopefully present them with a clear decision to operate but with increased risk that everybody accepts, or to refer for prehab and reassessment, or unfortunately a clear decision where it has been made not to operate. So thank you very much indeed for your attention, and I hope you have a great rest of the day. Bye-bye.
Thank you very much for these excellent presentations. I would like to thank the faculty, to all of you, that you have restricted to the time. So we have some time left for discussion. And we heard a lot about how we can improve quality while improving factors of the system, also of the surgeon himself, and also by selecting the right patient. So let me start off the discussion asking all of you. We heard from David Healy, from René Hausleben, and also from Federico with the Sigma process, that it seemed to be crucial to assign responsibility, to talk in David's words, in particular to some care coordinator following through the whole process. Can I ask the whole faculty if you have in your teams such a care coordinator implemented, and is this something that is supported by your hospital and a position that is financed? Maybe we can start with David, as he was starting this off.
You know, our system is not unique. A small country, about 5.5 million people, very resource restricted, but we still find it important to have such a thing. So we have 2 people. It's hard to have one person because people are on leave or get sick or move on and change jobs. So we've 2 positions that track the patient from the referral to handover to definitive treatment. And in our model, it's it's two nursing background trained people, but they will keep they'll keep the radiologist under pressure for the biopsy, and they'll keep chasing the PET scan results, and they'll, you know, push them into our clinic and move us along and constantly ask us when we're getting to the surgery date. So all that is tracked, and we do have someone that does that. And I really genuinely feel that it is important. And in particular, I do expert reviews for external problems. And often when there's a problem, I found that not necessarily the wrong thing is done, but sometimes people get lost in the system. And I think if there's a named person responsible for someone to track them from the beginning to end, it really makes a difference. As we pass from a physician to a radiologist, back to a physician, pathology involved, and ultimately maybe a surgeon, an oncologist, or a radiation oncologist. So there's a lot of different team members, and there has to be some central command. And while as I said, I think the surgeon can feel that they're at the end of things, and maybe they only take responsibility when the referral comes to them, but the consequences of all that process are yours as well. So you need to be involved and contribute to it.
Your hospital is paying for this position? How is it in your budget?
Yeah, so I would say 15 years ago, we were very disorganized, and it was so bad that the government had to do something positive about it. So they set up a central cancer control program. It's not lung cancer specific. Each cell line had the same model rolled out. And so we only have 8 centers that are resourced to process lung cancer across the country. Anything outside those centers has to be channeled into them. But those centers then are resourced to this. So the state pays the salaries for the coordinators, it stays our salaries, it funded to the diagnostics and all those sort of basic stuff. But yes, these are state positions, and they're quality controlled, and they're audited, and the performance is looked at. People do move on out of the jobs on occasion.
It's absolutely worthwhile. Yes, Renee, how's it in Denmark? You're muted, sorry.
Thank you, Isabel. It's very organized. It's organized at the national level. So for all cancer diagnoses, there are a law, a health law, stating how much the time for workup, for treatment. So for lung cancer, there are from referral from the practitioner, we have 28 days to decide at the MDT a final treatment, this be oncology or surgery. When referred to surgery, we had another 14 days. So 42 days altogether. If more than the 28 days are used in the workup, we have less than the 14 days. So it's 42 days from referral, the patient should be operated. This is constantly monitored monthly, and the administrators are punished if they do not fulfill these criteria by, I think it's 85% is the limit, should be within these 42 days. There is at every hospital several nurse coordinators that the patients upon referral in what we call as a cancer program or cancer package. So they can, this coordinator is connected to the patient, so they can call this nurse coordinator all the time if things are not strictly coordinated. And the patients who are usually falling between the chairs are the patients with several cancers, where there may be some, they may have different or several parallel courses, and the coordination is sometimes difficult to coordinate which surgery has priority, the kidney cancer or the lung cancer, which one goes first. And so the nurse coordinators, which are provided by the hospital and paid by the hospital, they coordinate this. The workup itself, we have, by inspiration from one of the hospitals in Denmark, now made a package. So when you are referred from the general practitioner, you get the full package with a CT, a PET CT, bronchoscopy, CT guided biopsy, a full lung function test. all of this is in a package. So when you're referred, you have 7 days where all these procedures are scheduled. And then if along the road it turns out not to be necessary, you can abort from them. But they're all in this package. So the postponement previously was because we waited for one result before we went to the next, and this I think has really speeded up things, but it's something that has a lot of political awareness, so it's really out of our hands, but I think it works very well, and it has definitely improved patient care.
Yeah, that sounds like the north of Europe seems to be pretty well organized, in particular from the state's perspective. I can only talk for Switzerland, where we have implemented this position, but it's not mandatory from the government. And it sounded like in Italy, from Federico's talk, it's the same situation. So there's still a lot of homework to do for us, I guess, in particular for our governments. Thank you for the statements. And I would like to move to a very important point that we talked about today as well, which is the surgeon's role himself. And Federico, you have a question for 3, right? You're muted, Federico.
Okay. Okay, can you hear me?
Yes.
All right. Yeah, I have a question from the audience for René. It's a technical question. It's about segmentectomy. They ask if you apply intravenous or intrabronchial 5-way application when you perform segmentectomies.
I do it intravenously, or to be more correct, my anesthesiologist is doing it intravenously. So I'm using 5 milligrams. There's a lot of debate about the dose. This is a rather low dose compared to other centers, but I think it's sufficient. So 5 milligrams of ICG intravenously is mixed and ready. And when I have the infrared camera in position, I ask the anesthesiologist to inject it. And the timing is very important, because in the first few minutes, you get a really clear border between the segments. But if you wait more minutes, there's often there's a diffusion of the ICG into the segment, and it becomes more blurred and more difficult. So the timing is important. It's very easy to do it intravenously. Of course, you can also do it selectively in the pulmonary vessels. I have no experience with this, but I've heard some Japanese are doing it. And then again, there are also, mainly in Japan, I think in China, there are surgeons who use dye intrabronchially, and this can be either ICG, or also there are some using methylene blue. But you should be very careful with this, because it can easily stain all over, and then it blurs your picture.
Thank you. Thank you very much.
3, maybe I can ask you a question. I really enjoyed your talk, and I think training resilience for our generation surgeons is super important. Do you have a fixed program implemented in your institution, how mindfulness and these things are trained?
So at present, yes and no, Isabel. There isn't a structured mindfulness program. But what we have in the UK is a portfolio of courses where the trainees are all brought into boot camp. So we introduce the importance of human factors, resilience, and all of those things. Because if you look at our specialty, it is a high-end specialty which is draining. And yes, in spite of European Working Time Directive and all those changes which have come, the trainees still, there's a big burnout. What we are trying to do is to liaise with the San Francisco group to see if we can replicate what Cartella Barres is doing in UCLA. There to incorporate a similar program so that it is an institutional level structured program. But at present, it's not widely rolled out.
Yeah, thank you for your comment. Federico?
Yeah, and do you experience a good compliance from our colleagues, from surgeons? Do they like to be involved in this kind of training, or do you think it's matter of culture?
I think it's a matter of culture, because when we talk to trainees to say how important it is, because the ones who become cardiothoracic surgeons are all your macho, high-end, I am an achiever, I'm going to do and make or break the rules. But what we hear from our American counterparts is when it is incorporated into the system to highlight the importance of their own well-being, which translates into better teamwork and better patient care, there seems to be a better compliance, but it is not mandated, and we'll just have to see how things evolve, because it has become a hot topic now, the mental well-being and the physical well-being of surgeons. I mean, there's just a campaign from one of the surgical royal colleges called To Moon and Back, so where they ask surgeons to pledge a form of exercise, and they will ask themselves whether they are well and check on their friends. So it is becoming quite topical. So if you ask me the same question next year, I'll probably give you a better answer.
Thank you, Sri. I really also like the comment from the audience that it's needed to have a change of culture there. And this is a request to the leadership here being in the faculty, that we have to give a different incentives, that we don't expect people not to sleep and to be always and ongoing and ever always being present and performing. So I think that's also a very important comment. Thank you to the audience here. And I have a very last and final question, because we also have not to forget about the patient itself. Which patient do we choose for surgery? And we had this excellent talk by Dr. Howard. May I ask you, where do you put in all these algorithms the emphysema patient who might even benefit from resection being completely hyperinflated? I saw your little asterisks in your presentation, but maybe you want to further comment on this here in this thoracic surgery round. Dr. Howard, are you still online?
We don't have the doctor.
Ah, okay. So maybe then we can just put this final but here as a final remark for the selection of these patients, that LVRS candidates might be considered differently when you use this algorithm. So it's not like a rule that counts for every patient, needs to be looked at individually, taking into consideration the area of the lungs you want to take out. Are there any further comments from the faculty or points you would like to mention here?
Isabel, I would like to reiterate what you've just said, because Leicester, we've had a very, very strong experience with volume reduction, and we take out patients who have FEV1s of 20 and 30%, especially if the cancer is in the lobe, which is not perfused and not functioning. So that message has to go out. There is still a role for lung volume reduction, lung cancer resection combination.
Yeah, thank you for your commentary. I think David wanted to mention something.
Yeah, no, I just want to emphasize that the idea of the surgeon's sort of well-being and general self-care, if you will, and their performance and the connection between the two is something that really wasn't a feature of life when I was training, but it's certainly something I've grown to appreciate. And I think it's a real issue and a real fact, and something we should all be conscious of. And I think if you look at sporting arena, it's not about turning up to the match on the day or just doing the training. All the high performance trainers, the Ronaldos or whatever of the world, are looking after themselves very well, and that impacts on their performance on the day on the pitch. And I think it is the same for us. This is a high performance enterprise, and how the condition you turn up on the day to perform it is important to how you perform. So I do think how sleep and general well-being, exercise, all that kind of stuff is hugely relevant. And the other thing I think that I would like to emphasize, and I think it's part of it too, is during the procedure, it is a high performance procedure, and the idea that you get distracted with multiple phone calls and minor things like that going on by people that don't seem to understand that this is a high performance enterprise is another element that we didn't really go into. But I do think that that section there on surgical persona, well-being, personal management is underexplored, underutilized, and has huge value.
Thank you, David. I think that was really a perfect final word. We're all aiming for the best, but we have to look for ourselves. And in that sense, I would like to make the break now until we have the next session about malignant pleural mesothelioma, which starts at 11 o'clock, right, Federico?
Perfect.
Thank you to the faculty again. It was really very exciting, this session. Thank you so much.
See you
And
later.
also to the audience.